You see somebody that's full of guilt, you might want to let them know.
Hello, everyone. It is my distinct honor to call this meeting to order at 1:50 p.m. A very warm welcome to our NAC members and who are joining us in person and virtually, as well as our esteemed guests who are joining us in person and virtually. We're here live in Baltimore for our June NAC meeting in advance of the Academy Health annual research meeting. This meeting is being recorded and will be posted on the AHRQ's website once it is available. Closed captioning is available for this meeting, and if you need closed captioning, please click the icon on the bottom of your screen. We're going to go ahead and do introductions. I'm going to start with our virtual folks first. My name is Komal Bajaj. I am a Chief Quality Officer for New York City Health and Hospitals, Jacobi North Central Bronx, and the Medical Director of Sustainability for New York City Health and Hospitals. I'm going to ask that as you introduce yourself, you say your name, your organization, and your role. We're going to go ahead and start with our virtual members, Peter Angood. We'll give Peter a moment. We'll move to David Ash.
Hi, I'm David Ash. I'm the Senior Vice President of the University of Pennsylvania.
Thank you for joining us, David. Elizabeth Mort. We'll give Elizabeth Mort a moment. Joan Galrud. We'll come back to our virtual participants. Excited to have so many smiling faces in the room today. We're going to start with Al Carter.
Good afternoon, everyone. Al Carter. I am the Executive Director for the National Association of Boards of Pharmacy, and pleasure to be here.
Excellent. I'm going to go in this order. Sharon Hickman.
Hi, I'm Sharon Hickman. I'm industrial and systems engineer. I have my own consulting company. So thank you.
Wonderful. Welcome. We'll get to our ex officios after the NAC. We're going to go to Jiaji Zhang.
I'm Jiaji Zhang. I'm the Dean of the D. Bradley McWilliams School of Biomedical Informatics at UT Health Houston.
Thank you for being here. Carrie Levy.
I'm Carrie Levy. I'm a geriatrician and palliative care specialist at the University of Colorado, where I serve as Division Head of Geriatric Medicine.
Welcome. Sunil Kripalani.
Hi, everyone. I'm Sunil Kripalani. I'm a hospitalist at Vanderbilt University Medical Center, where I serve as Director of the Center for Health Services Research and Vice President for Health System Sciences.
Mason Emmert.
Good afternoon, everyone. I'm Mason Emmert, and I'm the tribal epidemiologist for the Choctaw Nation of Oklahoma.
Welcome. Head this direction. We're going to go with Mary Beth Flynn Mockich.
I'm Mary Beth Mockich. I am a professor at University of Colorado College of Nursing and Schutz Medical Campus, and I'm a nurse research scientist at a level 1 safety net hospital.
Wonderful. Welcome. Michael Millison.
Hi, I'm Michael Millinson out of the Chicago area. I have a consulting company, Health Quality Advisors, and I consult, research, write, and try to be an activist about quality of care, patient safety, and patient-centered care.
So glad that you're here. Cincy Hernandez Cancio.
Hi, my name is Cincy Hernandez Cancio. I'm the Vice President for Health Justice at the National Partnership for Women and Families in Washington, D.C., and apologies for my extremely hoarse voice.
I'm going to go back to virtual in a moment, but last but certainly not least, Mario Molina.
Hi, I'm Dr. Mario Molina. I'm Chairman of the United States of Care. I sit on the boards of a couple of health systems for the University of Chicago and for Johns Hopkins, and spent most of my career in health insurance.
Thanks for being here. Back to our virtual NAC members, Peter Angood.
Hi, everybody. Peter Angood, President and CEO for the American Association for Physician Leadership. Thanks so much for the opportunity to be here.
Thanks so much for being here, Peter. Elizabeth Mort.
Good afternoon. My name is Liz Moore. I'm former SVP of Quality and Safety at Mass General, current primary care doctor there, and recently started as the Chief Medical Officer at the Joint Commission.
And Joan Gelrud.
Hi there, this is Joan, and I am the past Senior Vice President for Hospital and Health Plan Quality for Kaiser Permanente and Chief Population Health and Quality Officer for Luminous Health, and just thrilled to be here.
So glad that you're here. We're honored to have several ex officio members, both in person and virtual. We're going to start with our virtual attendees first. Deb Huri. Come back to Deb. Tom, I see you right across from me. Tom Buckmuller.
Yeah, hi, Tom Buckmuller, representing ASPE. I'm the Deputy Assistant Secretary for Health Policy.
Wonderful. So glad that you're here. Michael Lauer.
Hi, I'm Mike Lauer. I'm the NIH Deputy Director for Extramural Research. Glad to be here.
I have you as in-person virtual. Glad you're here, Michael. And we have Mindy Kidder as an alternate from the ONC.
Hi, my name is Mindy Kidder. I'm the Chief Nursing Officer attending today for Tom Mason, Dr. Tom Mason.
Wonderful. Thank you for being here. Let's loop back to Deb Howry. Deb, are you there? If we can't hear you if you're speaking. All right, we'll see if we can find you later. So a few other housekeeping items before we get started. I'm reminded, thank you so much. I would be remiss, I realized that Sherry Ling is on the line. Welcome, Sherry. Can you introduce yourself?
Hi, Sherry Ling, Deputy Chief Medical Officer for Centers for Medicare and Medicaid Services. I'm having a little trouble with my video. It says cannot start video because host has stopped it. So, but I think you know what I look like. So good to be with you. Sorry.
We'll make sure that we get that rectified. Thanks for making that note. So a few other sort of housekeeping. Again, we're so thrilled that you're here in person or virtually. If you'd like to make a comment in the chat anytime during the NAC meeting, you can look at the slide here and please send an email to that email address with the subject line real-time post. As with every NAC meeting, we have an opportunity for public comment. And please, again, email the address that is listed there no later than 3:15 p.m. Eastern today. We also will have public comment during the meeting tomorrow. And you can see that we'd like, if you could email us before 10 a.m. Eastern if you'd like to make a public comment. We ask that public comments are limited to 3 minutes or less. You know, I know all of us are here because we care so deeply about healthcare. I certainly, you know, have a very strong belief that all of us here are capable and we want to sort of do our best and improve. So I ask that you hold that assumption of me and that we hold that of each other. And so as you're making your comments, please keep them respectful. Certainly obscene, profane comments will not be accepted as public comment. So we've got a really robust meeting that really spans 2 days. Lots of important discussion will be happening over those 2 days. We're going to first start with comments from our AHRQ director. We're privileged to be able to hear about a vision for healthcare services research. We will have an update on age-friendly healthcare systems on day one. We will then have the public comment as mentioned, and then we'll round out our day one with talking about opportunities for modernizing the measurement of consumer experience. And then our day two, we will continue the robust discussion of priority populations and maternal health. We will have an update from AHRQ's Patient-Centered Outcomes Research Trust Fund, also known as PCORTIF, and the extension program. We will again have public comment, and then really hoping to have a little bit of opportunity of reflection as we sort of think about what we all have heard over the last 2 days. So it's now my honor to turn the meeting over to AHRQ's director, Dr. Robert Valdez, who will provide director's highlights.
Well, thanks very much.
Yeah. Thanks very much, everyone, for joining us here in Baltimore. We're excited to join Academy Health during the annual research meeting and interact with all of our colleagues and friends, many of whom we haven't seen for some time. But before we do that, I'm glad to welcome you to the National Advisory Council meeting for the summer, in which we look forward to your advice and your guidance for how we move the agenda forward at AHRQ. AHRQ, as you know, has a unique federal mission and role, and that is to make 21st century health care a reality for all members of our society. And now making that healthcare a reality for everyone requires really efforts and scientific evidence and tools that follow three scientific pathways. Biomedical researches and discoveries are necessary, but they're insufficient for the kinds of care improvement that we're trying to make in our society. AHRQ's congressional authorities focusing on healthcare has us doing this in four different ways. We generate scientific evidence. We also disseminate and help implement what I like to call actionable knowledge, and that is the body of evidence around a particular topic or issue that healthcare organizations and clinicians need to know to improve the care that they provide to the patients and to the families that care for them. We're also asked to improve primary care in our country. Primary care is fundamental to a strong healthcare system, and this particular authority was included in the Affordable Care Act as a central role of AHRQ. And all of this is to be done in partnership with patients and in partnership with the private sector that operates the vast majority of healthcare in our country. I like to say that AHRQ is to healthcare systems as CDC is often thought of as to public health systems. Now, AHRQ has been celebrating 35 years this year of this effort to try to create the path to medical progress or healthcare progress. And AHRQ is the outgrowth of Congress turning us into an agency from the National Center for Health Services Research and Healthcare Technology Assessment into what is now the Agency for Healthcare Research and Quality. And it's these other two paths, technology assessment and health services research in the real world, that are the two intersecting paths with biomedical research discovery that leads us to the kinds of healthcare progress that we strive to make each year. Well, AHRQ over the last 35 years, just to give you one example, has been very much involved in the whole issue of patient safety. We funded the early research that went on before To Err is Human, the National Academy of Medicine document that actually documented the findings about patient safety and patient concerns. We developed a variety of tools over the last 35 years that include team steps that recognize the need to work in partnerships across different teams within healthcare settings. We developed a variety of different surveys and innovative efforts that looked at patient safety culture in organizations and stood up patient safety organizations around the country. That's a way of trying to make headway on what was then considered a vital concern and is today. In fact, the pandemic set us back some ways in patient safety. We had slow but steady progress on those areas in which we focused. We didn't make so much progress in those areas we didn't focus on. But thanks to the Secretary, we've launched the National Alliance for Patient and Workforce Safety, and working in partnership with our colleagues across the department and across the federal government, we're actually beginning to make some headway regaining the safety that's required and the trust that patients look for in the work that we do in our healthcare systems. In the last year, 85% of hospitals have seen improvement in at least one of the three hospital-acquired infections that is tracked by our partners in the National Alliance, the Leapfrog Group. And so I think we're trying to gain traction. The American Hospital Association and other organizations have also joined forces to really focus on patient safety, using the tools that we've developed over the last 35 years and developing new and better ways in which we can move forward. I would be remiss in not speaking to our council about our budget situation. This year, we're trying to implement the $369 million that Congress appropriated for our work. It's a decrease about $4.5 million from the 23 enacted budget. But in addition to those funds, we have about $118 million from the Patient-Centered Outcomes Research Trust Fund. So using the trust fund dollars for our dissemination and implementation work and our educational and training activities complements the work that we're able to do on the evidence generation and evidence synthesis work that allows us to build the tools that I was just describing and upgrade them and modernize them. The president has asked for fiscal year 25, $387.3 million. That process, as you know, has just begun. The House just this week put out their mark, and unfortunately, their starting point is an elimination of the agency. But we know that this is a long process, and we're quite confident that other members of Congress will see the importance of the other two paths of science that are necessary to actually make the progress that our society wants. We've also just now begun the process of the 26th budget proposal, which will be reviewed by the department a week and a half from now. And then after the department is finished with its review, it'll go to the White House for consideration in the president's budget, which will be released early next year. Today's discussions and tomorrow's discussions are extraordinarily important for us to continue making progress. We're going to be continuing our discussion about how we should be measuring and understanding consumer experience, because as you know, in this kind of service industry that we operate in, consumer experience is central to actually driving improvement in the kinds of products and services that we're able to provide in our industry. We're also going to talk about issues around health equity, because as I noticed, our mission is quite literal in that we're to improve healthcare for all. And yet we've known for decades that there are huge disparities in healthcare and in health among various populations. Just yesterday, actually, the National Academy of Medicine released a report that we co-funded with the National Institutes of Health to re-examine the 20-year-old report on unequal treatment. And what I hoped we were charging them with, and I think they've made some progress on, are recommendations for what I like to say is vanquishing racial and ethnic health disparities or health inequities. And lastly, we have an important opportunity to do something that is extremely important to do, and that is to reduce the time gap between scientific innovation and practice. And we have put forward a proposal called the Healthcare Extensions, and they'll be state-based because, as most of you know, states are really the true drivers of healthcare in most of our communities. Although we also have tribal communities and we have territories and others that also are playing in that particular game. As a federal government, we and this particular agency, we recognize the need to work intimately with those organizations and those governments to make sure that we reduce the time from innovation to actually practice. And so I'm excited to hear about your ideas, your reactions to these ideas, and how we might actually make some progress on these various initiatives. Thank you.
Thank you, Dr. Valdez, for those highlights. We have a few moments, and I would like to invite members of the NAC if they have any comments or questions for Bob. Feel free to raise your hand via Zoom or enter into the chat if you have a comment. I see, Michael, you have your hand up.
Thank you for that. So I've been doing patient safety for a long time and am not a great fan of voluntary efforts, even if they have names like National Action Alliance. And I looked at this, I had not heard that 85% improvement statistic, and it's not on the website of the National Action Alliance either. And my question was, if 85% saw improvement in at least one of the 3 infections tracked, how many had either no progress or went backwards on any of those indicators as well? And what percentage of the hospitals reported?
Yes, the answer is the 100 minus 85, as 15% have made no progress or have gone backwards in their progress. And in fact, we're taking advantage of the work that our partners do in the National Alliance.
I make the question clear. 85% could have gone forward on at least one, but they could have gone backwards on 2. So that doesn't translate to 15%. It could be the 85% made progress on 1 and 85% also went backwards on 1 and whatever. So that's the question.
I understand the second half of your question now, but the vast majority of those that made progress stayed at least stable with making progress on the other infection. You have to have at least some base, but if they actually went backwards, that kind of nulls them out. But it's clear that we still have a large segment of institutions that have not made progress. And I'll point out to you again that Leapfrog only looks at hospitals, and hospitals that participate. And so they have a small share of hospitals that don't participate in some southern states in particular that worry me, and that we clearly need to do a better job with. I'm also concerned about the fact that we know that patient safety events occur in other settings. And in fact, we've documented that at AHRQ and at CMS and in other partners. And we're trying to get a handle on how we do that. So part of the National Action Alliance, as you'll learn, is trying to build a dashboard to actually gain some better sense of how we track across settings, as across states and across localities.
Simply suggest that AHRQ keep the website of the National Action Alliance up to date with more detail. And they also get themselves a LinkedIn site. I understand LinkedIn, Facebook, things like that are catching on these days. So
thank you, Michael.
And press releases.
Yeah, thank you, Michael. We're going to go to Joan and then Cincy. Joan.
Hi, folks. Can you hear me?
Yes. We can hear you.
Great, thank you. So patient safety in general is a passion for me. I say this all the time. If people come for help and we're hurting them, we don't need to be here. And the complexity of providing medical care across all settings makes it harder and harder to keep people safe. But I wanted to underscore your comments about looking in the hospital, but also across the continuum, because once you get out of regulated spaces, it's sort of the Wild Wild West out there. And there's so much opportunity that I think if we could marry workplace safety, patient safety across the whole continuum, the impact would be transformational for our citizens. Thanks.
Thank you, Joan. Cincy.
Hi, yes. My question is along the lines of what Michael was just mentioning. 85% on 1 out of 3 sounds really great. When it comes to health equity, which is the next priority, it's unclear to me whether are we only improving for some populations. It's very possible to see an improvement overall and still see particular populations actually doing worse. And so I was wondering if you have that data, how you can make it available, and if there's anything you can comment on the distribution of that improvement.
The leapfrog scores are available publicly. Anybody can look them up. You can look up your local neighborhood hospital or the one that you happen to be using to figure out how they're doing and on the measures that leapfrog tracks and maintains. And you're absolutely right. There are clearly some regional issues. There are clearly some, as a result, demographical concentrations where we know there are issues, and we're taking an active role in reaching out to provide the kinds of tools and guidance that AHRQ has made available. But instead of waiting for them to come to us, as has been the case in the past, we're moving out to them.
Thank you for those comments. I'm now going to turn to our next order of business, which is something that I forgot in my zeal to get to our conversation. I forgot if they're to approve our minutes from March. And so I'm going to ask if there are any changes or edits to the draft minutes from our March 14th meeting. I see none. May I have a motion to approve the minutes? Carrie, thank you. May I have a second? Thank you, Al. We've gone ahead and approved the minutes. Thank you for that, for indulging me. It's now my real delight to introduce Dr. Erin Carroll, who is President and CEO of Academy Health, to discuss the vision for health services research. As a reminder, full bios are available in the meeting packets, because if I was to read his bio, take the whole meeting. Thank you for joining us, and the floor is yours, Dr. Carroll.
It's my pleasure, and thank you so much for having me. I know some of you, but not all, but I'm Erin Carroll. I'm a pediatrician and health services researcher by training. Previously, I was at Indiana University for 21 years in a variety of roles. But have recently, about 3 months ago, become president and CEO of Academy Health. And I've always been a huge fan of Academy Health's mission, which is to advocate for the creation and use of data and evidence to improve health and healthcare for all. Obviously, that aligns very closely with AHRQ's mission. Many health services researchers, including myself in the past, have been dependent and have benefited from the funding that AHRQ gives out, and of course, the guidance that all of you have provided. It's a pleasure to talk to you today. I understand what it is like to be on a national advisory committee and what a commitment that is. And I want to say that Academy Health and researchers in general really appreciate the work that you all do, volunteering your time to help make AHRQ and health services research better every year. I was asked to talk about a vision for health services research. That's, of course, very broad. We could spend hours and hours talking about what I think or what we all think health services research could or should be. But I really appreciate the opportunity to talk to you about what Academy Health is thinking about and also what I am thinking about. And I'm going to confine my remarks to 5 main points, and especially as these align with AHRQ's authorities, which we were just reminded of, to generate evidence, to disseminate and implement actionable knowledge, to focus on primary care, and to work and partner with patients and the private sector in order to improve health and healthcare. The first area I'd love to ask you to consider to focus on in the future is a commitment to innovation in health services research in 2 main areas, both in the methods that we use and also the areas that we choose to focus on. I was reminded this morning in another meeting that health services research often does an excellent job of conducting observational research, but doesn't focus as much on interventional research. I think of this in another way. We in health services research are very, very good at pointing out problems. We're not as good about proposing solutions. This makes it very difficult to convey the importance and necessity of health services research because we can keep pointing out how bad the healthcare system is, but until we start pivoting to talk about how do we make things better, it's hard to continue to grasp or hold the focus of the American people as well as Congress. For that matter, we have to do a much better job of communication. one of the things that I have been very focused on in the last decade and more is on science communication and how we talk about the results that we as researchers develop and how these can actually improve health and healthcare for all. We're not very good at it. We're not even very good at talking about what health services research is or why it's important. And we, as researchers, need to get better at that. And we train and have investment in developing those skills in order to make sure that people both understand the importance of health services research in general, but also how and why they should care about the results that we find. Another focus has to be on implementation. We all understand that we can generate research, but unless it's adopted and used in the real world, it doesn't have the impact on actual health that we all care about. A second area that I would urge everyone to continue to focus on is the importance of continuing the work that we do with equity inclusion in the health services research workforce. We all know that there is evidence pointing out, again, that problems exist in this area. We continue to publish research all the time on gaps in diversity and in equity, but we need to also focus on how do we make things better. And one of them is by continuing your focus to continue to work with less research-intensive universities, HBCUs, and minority serving institutions. World Academy Health have recently engaged in both a literature review and in some significant qualitative research to assess the comparative advantages and disadvantages of HBCUs and MSIs. And as always, it's easy to focus on the challenges, and they are real. A lot of these types of universities do have the massive research grant getting infrastructure that larger universities have, which make it much easier to obtain funding. They also often have heavier teaching loads, which makes it harder to, again, be competitive with research. And of course, there's the structural racism, which we all know is prevalent in the grant-making process in general, that I know we all continue to work to dismantle, but still exists. But there are also advantages that HBCUs and MSIs have that are equally important to focus on, especially as we want to talk about how we might make things better. They often have trusted relationships with both minority communities and local communities, which are essential in doing community-based participated research. Also essential for implementation, because with better relationships with those communities, it is easier to implement the research that we might find, and therefore make actual improvements to the healthcare system. These types of universities are also really good at providing skills in resilience and persistence, which serve many researchers very well, especially as it becomes harder to obtain funding. They also teach a bit better how to work in under-resourced environments, and I think everyone benefits from that kind of skill set in learning how we might make do with more with less. But it's also important to focus on the fact that we need to support mentoring and community building in these communities to get new voices and new people involved in this work. That could include new funding areas, more focus on early career people as they develop into their jobs, and on focusing on a broader network than just academia, because a lot of people, especially these days, are doing really good research outside of the academic environment, and it's important to both bring them into the HSR community and also support their work in both gathering and then disseminating evidence. A third area for focus is in incentivizing community partnerships. I think we all know that there's value in creating community partnerships that are both relevant and then responsive to research. You know, all the way back in, the long ago of 2004, one of AHRQ's evidence-based policy centers published one of the first systematic reviews on community-based participated research. And you have done significant work in continuing and fostering that in the next 2 decades. And HSR health services researchers all over the country continue this work, but it often doesn't fit into the usual funding mechanisms. In a standard R01 independent investigator grant, it's very hard to do community-based participating research. It needs a different focus. It just needs a different set of skills or evaluation criteria in order to decide how might we judge if this is research worthy of funding, and then also how to bring other people in. Good community-based participated research needs legitimate partnerships with power and budget sharing. But that's hard to do in the traditional grant making process, where study sections perhaps don't understand or value the importance of involving community-based organizations. At Academy Health, we have focused on this more and more in recent years. Our Community Research for Health Equity program supports community-led research projects and requires that PIs be either community-based organizations or an equal co-PI. Of 10 awarded grants, 6 have gone to community-based organizations, and we assess all of those partnerships for equity in terms of leadership and resources. A lot of these projects are still underway, but our preliminary results show that all the grantees report many strengths and few challenges. I think we've also seen in the public a lot of patient-driven research communities or patient advocates that have been PIs or co-PIs, and many advocacy organizations can serve as prime awardees. This is one of the ways we can translate efficacy into effectiveness. If we are involving community-based organizations and organizations that actually do the work through all the steps of research, it's much more likely that that research is going to get used sooner and better. And given how long it takes to translate so many results into actual healthcare, this can only be seen as a positive. A fourth area I'd like you to consider as we think about a vision for a future HSR is having more flexible funding mechanisms in general. One of the things that we've been most, or at least that I can say in my first 3 months at learning about Academy Health, one of the most innovative and things that I've taken pride in is our evidence-informed State Health Policy Institute, which involves 3 different groups: the Medicaid Learning Directors Network, the State University Partnership Learning Network, and also the Medicaid Outcomes Research Network. And in all of these, we are not necessarily doing the research, but bringing together lots of organizations that are doing the research, letting them help learn from each other and helping them to take the work that smaller or individual Medicaid programs are doing and leverage it to other programs so that we can use data across Medicaid programs, but also implement the learning that comes from doing this kind of work to other universities and other Medicaid programs. It's like, I think of it as almost a force multiplier. It's that we can leverage the work that's being done in one state or one area across many others, and therefore make a lot of the work that's happening much more impactful. You can't do that kind of work again with a standard R01. It doesn't exist. And it's also, it requires convening. It requires bringing people together. It requires meetings. Yet small conference and even large conference grants haven't really increased in size in many years, which means that as the cost of travel has gone up and as the cost of hosting meetings has gone up, we have to start limiting the number of programs that can come to such meetings or who can attend. I would like to advocate that we think of increased funding for more meetings and more opportunities and more networks instead of trying to fund one-off programs. In the basic sciences, for instance, you can get an R01 and renew it for years and years and years, which allows you to build a lab, which allows you to then keep developing things along. We don't have that kind of structure in health services research. Any R01s that we get are usually one-offs or secondary database analysis. And after that, we are done. And it is hard to implement, and it is hard to network, and it's hard to bring that type of group together. I think we need to think about new ways of funding the important work that we think needs to happen, some of which I've already described, but that allows us to continue that work in the long term, which requires us to think about how do we bring people together and how do we form networks of what otherwise might be occurring and what other work might already be happening. Finally, I would be remiss if I didn't, in the fifth idea, focus on AI and digital healthcare research. We are all aware that we have reached an inflection point with respect to artificial intelligence. AHRQ has had a long history of leadership in health information technology and data data-focused work, all the way back even to the Clinical Decision Support Innovation Collaborative, which of course, again, was a group of diverse stakeholders at the forefront of using technology to better support care teams, patients, and caregivers. And I bring this group up specifically because it's a good example of some of the other things that I've discussed. It's a network. It's a learning collaborative funded by AHRQ, which is focused on an area that we all recognized was important. We're going to need that kind of collaborative and learning network as we move forward with artificial intelligence as well. We're also going to need to make sure that we are involving good research as we implement artificial intelligence in both healthcare and healthcare research. We have to be able to focus on the harms and not just the benefits, which we always weren't good about with information technology and computerized electronic medical records and even computerized physician order entry. These kinds of technologies can make things worse as well as make things better. And we need to make sure that we're there doing that important work. We also need to recognize that there are multiple types of artificial intelligence being pushed at the moment. I serve as an editor at JAMA Pediatrics, and almost all the research that I've seen come across our plate so far has been, can we use ChatGPT to replace physicians in both looking at responding and talking to patients and also in trying to make diagnoses. Artificial intelligence is going to be used in those ways, but it's also going to be used in the background in doing risk assessments, in assisting with diagnosis, with assisting with prognosis, determining how we might care for patients, but it can also be used at very high levels to determine when patients might be ready for discharge. How can health systems be more efficient or make more use and try to make more money and more revenue, if we're being honest? All of these could have benefits, but they could also have harms. And we're going to need to advocate for standards, and we're going to need to push for toolkits and all of the things which can be boring but are necessary in order for us to conduct good research into how these new technologies might be used. And I'm proud to say we're going to have a number of sessions at ARM on these topics, and I look forward to attending and learning at all of them. So to recap, I think it's important that as we talk about the future, we think about innovation in our methods, as well as the focus of what research might focus on. It's important that we keep looking at equity and inclusion in terms of health services research in many different domains and ways, that we continue to focus on community partnerships, but expand them in both our focus and our funding, that we think about new flexible funding methods which might add skill sets to what's necessary in health services research while continuing to focus and develop both people and projects in ways that matter and also will be actionable in the future, and that we don't miss our chance to be here at an important moment as we talk about research and the use of research on artificial intelligence, and also how we might study artificial intelligence as we move forward. I encourage you as a NAC to consider these and prioritize them in your recommendations to AHRQ, but also think about the other ways that health services research might impact the field and do a better job in trying to improve health and healthcare for all. I think there's a real opportunity for us to continue to focus on data and evidence and talk about how they can be used to improve health services and health policy, to improve health and healthcare for all. I once again want to express my gratitude for this opportunity to talk to all of you. I am more than happy to take questions about this or anything to do with Academy Health. I'm hoping many of you will stick around for the ARM meeting that's going to be occurring over the next few days here in Baltimore, and that you'll continue to stay in touch with Academy Health as we move forward. Thank you.
Thank you so much, Dr. Carroll, for sharing your vision, honoring this moment and thoughts for the future. We have about 30 minutes for comments and questions from the NAC. Peter has already raised his hand and put a question in the chat. Peter, would you like to unmute yourself?
Yeah, thank you so much. And great presentation, Dr. Carroll, and congrats on the position and a strong start in your new role. We look forward to working with you in the future. My question is more from, and it's in the chat as well. Can you, in that description, you didn't cover the other sectors of the industry, the for-profit sector, who often fund research. And that's evolving very rapidly in a whole variety of ways. Could you further comment on that interface with HSR?
Yep. And so if you'd asked me to comment on Academy Health versus health services research in general, certainly this would have been in my wheelhouse. There's no question that a significant amount of good health services research is coming out of the private sector these days. A lot of for-profit companies have access to significant amounts of data that are sometimes not widely shared that allow them to do database analyses and studies that could not otherwise happen. They also have sometimes deep pockets where they can focus significant efforts onto answering questions that still pertain to a lot of the things that I think talked about in my remarks. About half of the health services researchers that our Academy Health members come from academia. That means half of our members do not. They come from nonprofit and for-profit companies. They come from think tanks. They come from government or otherwise sort of designated agencies, and all of them are doing important work with health services research. One of the things that I've talked about internally in the first 3 months is that I feel we need to reach out and bring a lot of those who are not academic into the fold, to recognize that there's an incredible amount of work that goes on, again, in nonprofit and for-profit companies. I'd also argue that some of the things that I see happen in journalism and media with respect to telling stories and the use of data qualify as health services research, gathering up data sets, putting them together, trying to tell stories about what this means for actual health problems. That is health services research. We need to do a better job of explaining why that's so, and then again, bringing them into the fold. But one of the things I expect to engage in as president and CEO in the next year or two is probably some sort of West Coast swing. I shouldn't be pejorative. I'm sure there are other parts on the East Coast as well. But in trying to meet with a lot of the companies that could and should be doing this important work. And again, trying to bring them into the health services research fold so that we can all do a better job.
Thank you very much. And not to forget all of the various patient advocacy groups in that type of an answer as well.
Again, as well. And in fact, patient advocates, I've been remiss, are also a part of Academy Health. And we have had significant focus on involving them in more of our meetings and activities. You will see them on a number of different panels at AHRM. I was just at the Health Data Leadership Institute a month or two ago, where patient advocates sat on panels. And I actually just did a podcast earlier this week with one of our members who is a strong patient advocate and works both with PCORI and AHRQ. So absolutely, that is another area of focus that we need to continue to work on.
Thank you for that question. Michael.
So thank you, Aaron. Really thoughtful. So for me personally, it's been something I've been thinking about a lot. 30 years ago, I left journalism and became a health services researcher, inspired by going to AHSR meetings, and was actually on the board of the old Association for Health Services Research. And I remember telling them that HSR is about saving lives, and if you spend 95% of your article on methodology, and then the last 3 sentences you say, oh yeah, I figured out how to cure cancer, you're not going to get much publicity. And there are a couple of things that, those of us in quality and safety like to talk a lot about changing physician culture. But when I look at academic culture, I see a few things also. And if you think of HSR as saving lives, as opposed to saving tenure, there are things that you would look at askance. And so, for instance, I'll give you the real world and then also timeliness. So there was recently an article published on outpatient patient safety from some of our friends at Harvard. In the real world, if you looked at that and you said, why are these data 8 or 9 years old? You would go, this is people's lives. Can't we get something more recent? In the academic world, nobody ever looks at the dates. And where I find this even more, and I've been a peer reviewer for journals, is I'll peer review journals on something tech. And they're quoting stuff from years and years ago. And I did an article on direct-to-consumer apps, and stuff is really old, as if writing about the 2016 iPhone relates, or Google relates to today. And the academic culture, which is where AHRQ could affect because we have the money, doesn't care. You just keep on quoting stuff all the way back. You don't even check half of it. Just like things take 17 years to disseminate. It's an old statistic which may or may not even be true, et cetera, et cetera. So if you are about saving lives, particularly when it comes to things that are lives, the culture should say, no, I know you shopped this around forever, but we need to have more recent data. And I know that there's problems with that, some data sets. So timeliness. The second thing is, I guess to me, is intersects as an ethical issue, because publishing old data on things that affect people's lives, as opposed to my wife's an art historian, it doesn't really make any difference, is publishing articles about patient safety that are amoral. And what do I mean by that? If you submitted an article that said, what's the return on investment of treating women with breast cancer? Can the hospital make a profit doing that? I suspect that would not be published. On the other hand, you regularly have articles about the return on investment of profitability of various patient safety techniques, including, is it worth our, and then the academics don't even have the courage, or the editors, and this is where we have to get to editors, to say what they've seen. So you have an article, the conclusion is hospitals won't pay 88 cents a bed to keep grandma from falling and killing herself. Now, if we said it that way, we might get some publicity for patient safety. Instead, we don't. And so we need to have editors who look at this. And one last comment. I've been doing this for over 30 years. The worst article I've ever seen in my entire life that got no publicity other than me looking at it and saying, oh my God, is it worthwhile preventing CLABSIs, which is a serious life-threatening infection, in kids who are hospitalized with blood cancer? What's the ROI of that? And not only did I have an ethical problem with printing it that nobody cares, but they never do the economics right and say, well, if they die as opposed to they're sick, we save money. So if you're going to do economics sloppily and not do it right, but really health services research needs to look at its culture. What do we print? Why do we print it? When do we print it? What's the timing of this? And start to have the kind of things that you talked about trickle down to the editors. And that's where I think AHRQ, as the payment agency, has a lot of clout.
Thank you, Michael. Your response.
There's a lot to respond to there, and I'm going to try to. And I will be honest, the first thing is that I was panicking when you said the worst article I ever read. I was afraid you were going to say it was one of mine. So I'm glad it wasn't. But I think you bring up a lot of really important points. I would argue that a lot of them are a critique of science in general, though, and not necessarily health services research. We did a podcast a couple of years ago, actually NIH sponsored, which was part of their trying to improve reproducibility in research portfolio. And we talked about what's wrong with the culture of science and how does the culture of science and what is wrong with it affect the quality and reproducibility of the research that is made. It's everyone's fault from the top to the bottom. It is, how research is done by academicians, how they go to get grants, how the funders incentivize the grants, how academic environments, universities are set up to incentivize how we go and get grants. What is likely to get published, meaning that the publication system is incentivized wrong. The media and how they promote what might get published is incentivized wrong. All of it is incentivized in a certain way, and none of it is to how do we get the best science to get published quickly and save the most lives, which is what you're describing. But we can't fix one piece of it, which is, part of the difficulty in this. I can't change how universities are going to structure themselves to do research as long as the funding mechanisms are changed, which is why I would advocate we need some changes in the funding mechanisms. I can't change how the journals will work as long as the media, and then how all of that will work until they're willing to pick up on it. I can't change how the scientists will work as long as the universities are structuring it wrong and the journalists are, and the journals are like, it all needs to be part of a collective effort, which I think is massively important. And I could not be more excited to work on, but it will require a lot of change in general. One of the things you pointed out, I think, was the timeliness issue. And, 17 years, 15 years, whatever it is, it's too long. But that part of that problem is science's problem, but part of that problem is also implementation. And how does the healthcare system and how do clinicians and how do state, departments of public health and other organizations both get and implement research? And that is also not optimal. And we could fix everything about what we've described with research, but until we also fix how do we connect that to the implementation of the research and the organizations that are actually going to do this work, it's still going to be a barrier. I don't want to minimize how much work this will take or how expensive it will be. I do want to maximize the fact that there's so much potential to do good, that by working on these topics, that by investing in them, and that by showing the way that there could be different ways of doing things, we can make a massive difference. I will say one more thing, and then I will let stop unless I missed any of your points. If I'm going to be specific about health services research in general, though, I do think we suffer from an inability to promote our own successes in a timely manner that matters. It's the only sports analogy I ever use, but I think it's a reasonable one. Most basic science work and most funders want a grand slam. They want something splashy and huge, a cure for a disease. Something that radically changes, the world, drugs that all of a sudden massively combat obesity. Health services research only produces singles, but it's singles every day. It's constant. How do we prevent this? How do we make it slightly more efficient? How do we improve it? How do we improve a vaccination rate? But singles every day is how you win games. It's how you win a World Series. And no one is just trying to hit grand slams. Any good team wants the fundamentals, wants to improve what we do every day. That's health services research. It's not flashy. It doesn't make for great newspaper articles all the time unless we get much better at talking about it and talking about why it's important and telling a good story so that the media will want to cover it, so journals will want to publish it, so people will want to implement it, so that everyone recognizes how massively important it is, and that's how we'll make things better.
Thank you for that sentiment. 1% better every quarter adds up. We're going to go to Cincy, then Jaji, then Michael. Cincy.
So I feel a little weird saying this in the shadow of Camden Yards. I'm not a sports person, but that analogy made a lot of sense to me. I wanted to, first of all, talk about the issue about implementation. And I think that all the things that you said are correct and need to be fixed. But at the end of the day, what gets implemented is what gets paid for. And so even if we get to the optimal of all the things that you said is going to take, a lot of money and a lot of time, if our healthcare system doesn't pay for the things that we know actually work, and we know that right now they don't. Like right now, the healthcare system does not pay for things that we know work, that there's ample evidence for. And it has a lot to do with what he was talking about of like, who's going to make the money off. But that's the whole other thing. But I wanted to just add that layer of the complexity. I wanted to very much thank you, as somebody who's been working on health equity issues for all my life, for talking specifically, naming the fact that we always talk about all the benefits that may happen and all the benefits that do happen without looking at what are the harms that could happen and what are the harms that actually are happening, right? As, the update of, unequal treatment continues to tell us. It's very exciting to me to hear that that is your vision, that we need to look at that as well. And, people who know me, and have heard me say this before, we need to look at how benefit is distributed and how harm is distributed among different population groups.
I want to respond to two different things that. Oh, I'm
I
sorry.
was coughing. I'm sorry. But the last thing, a lot of that is one of your other themes is bringing more people into the fold and understanding the role that nonprofits, I've worked for nonprofits, bringing in the patient perspective, the patient and caregiver perspective, more community-based participatory research. Our breakout earlier was all about how do we make sure that the right people in the right communities are able to do the research, and the issue of power and funding and budgets. So I think that you're positioning, in my opinion, Academy Health to go into what would be a much more fruitful direction that, if COVID taught us anything, we desperately, desperately need. So thank you.
I appreciate all those remarks, and I apologize for interrupting. I want to respond to a few things. The first is what you were saying about return on investment, when that we can't pay for things that we know work already or that we prove. The reason for that is because we're willing to pay so much for stuff that doesn't work. I was at the American Public Health Association on a plenary session right before the pandemic, and I was urging public health in general as a field to stop the framing that seems to have happened where we demand that public health be cost savings, that not only that it be cost effective, which it massively is, but it must return on our investment. We require most medical care barely be cost effective, let alone cost savings. We approve things all the time that are barely effective, let alone cost effective. But for some reason, we require so much of what we might do to be health savings. One of my favorite columns that I ever wrote was that, the Robert Wood Johnson Foundation years ago did a study on public health interventions to see, does prevention save money? And at the time, the only thing that does is vaccines. I think maybe baby aspirin did at the time as well, but that was it. Everything else was massively cost effective, but not cost savings. We got to get out of that frame. We have to recognize good things sometimes cost money. But we are afraid as a field, I think, sometimes to do that. Pharmaceutical companies aren't. They're more than willing to say, no, these things cost, you want miracles or even want good drugs that cost massive amounts of money. So does a lot of the stuff that we do. And we have to stop that kind of framing. To bringing in new voices and bringing more people to the table, especially patient groups, it is critical. I'm amazed at how many meetings I've sat in on the last decade, which talk about how hard it is to get patients and the public to want to participate in research. And in the same breath, they also are like, oh, but we can't have patients at the table while we do research. Well, then why are they going to participate? We have to be better about involving those we need and who are going to be affected by this research to be able to talk about it and feel like that they're contributing in some way and that their voices are being heard. Without that level of trust, which is going to mean good communication and the ability to be vulnerable with each other, it's going to be harder and harder to do the kind of research that we need, unless we're just willing to commit forever to observational research and secondary database analysis. But if we want to actively involve people in the work that we are doing, then that's how we're going to have an impact. We're going to have to be better about including them at all levels of the work.
Thank you. Jaji.
Okay, I want to make a comment on your number 5, AI and data science. I'm the dean of the School of Biomedical Informatics. In our school, we have dedicated department of AI data science. Okay, and that's the background. I totally agree with you, the huge potential of AI, which is actually real today. It's not a hype. If you still think it's a hype, talk to me. I will convince you. Literally, it's a fundamental economic transformation. I came here on a flight with engines on an airplane, took about 3 hours. I could drive, it would take me 5 days, bike, several weeks. If I walk, several months. And it will cost me more than $10,000 to walk from Houston to New York City or to Baltimore. Okay, if I do that. Okay, so basically engines has diminished the physical cost. AI is going to diminish the cognitive cost. Okay. So with this background, one comment I want to make is that I think today we have everything to fundamentally change the whole ecosystem of medicine and healthcare from the medical education. I think if you heard about the test by the machine, the medical license exam, more than 90% accuracy. It only takes 60% accuracy to pass the step 1 exam. Think about this, how this will change. And then for the medical diagnosis, imaging, whatever, and then biomedical discovery, the AlphaFold solved the problems of protein folding, like at a scale that can produce several million structures. In old days, it took one PhD to get one structure. Okay, all of this happening today. We have a perfect infrastructure for everything. So now how to get health service research into this? You have all the data, you have all the tools. Now I think the critical point is to design the implementations, make it a change. As you mentioned, implementation is typically not part of health service research in the past. I think now is a great time to make that happen.
I appreciate the comment. I would agree. I just think it's going to be important for us to reach out also to, I think, a lot of the companies that are going to be doing this work to make sure that we can convince systems as they implement them that we need to continue to study them as they are implemented, looking as we talked about before, both benefits and harms. I think you're absolutely correct. It's happening. It's not just it's going to happen, it's happening. So we can't sit around in our usual timeline of decades or years to figure out what's going on. This is something I think we need to move on quickly, which will take, I think, resources, but there's lots of people who are knowledgeable and dedicated and ready to do the work. We just have to get to work.
Thank you. Michael.
Yeah, great. It's Mike Lauer, NIH. I'm not there. I'm virtual. So thank you very much. These were fantastic remarks. Congratulations on your new position, and congrats on all the terrific columns that I often read out loud here at home. So I have a question for you. If you could wave a magic wand and change the funding mechanisms in any way you wanted to, what would you do?
Wow. I think that, I mean, if you're giving me magic power, I really think what we need to do is start to decide what we want to accomplish and then figure out what's the most expedient way to get there and then fund that work. And that will mean telling people they have to come together from across different universities, across different disciplines, across different methodologies, setting out a timeline with benchmarks and KPIs and what steps we need to take and how we're going to do that. And it would require the breaking down of a huge number of silos. But it would also require people to abandon their usual ways of getting grants and doing the work, which is hard to do because it doesn't require just fixing the funding mechanism. It also requires fixing how people are rewarded with tenure or promotion in academics, how they can work with private and nonprofit companies, how they should stop focusing on a tiny niche, which is the traditional way of succeeding in independent investigator work, and instead be part of a big team doing science together. And also acknowledging that it can't be funding individual tiny projects, which then we have to wait years to see if they work. It means, constantly evolving the ways that we're evaluating the work that we do and making changes accordingly. None of what I just said is possible with current funding mechanisms or the way that science is set up now. But it's possible with resources. And it is possible if we can change the ways that we describe and do science. I'm optimistic about it because it didn't always used to be this way. If you look at sort of how Bell Labs and originally how even academic research was set up in the long ago, it was more, we funded people, not ideas. We funded projects broadly to accomplish big goals, not small niche things that people are incentivized not to work together on. But as more and more money got involved, and as the whole academic industrial complex got set up, we have moved further and further away from that kind of team science. I would be thrilled and heartened to see anyone take a step forward in trying to change the entire sort of scientific structure of how we do this work that's more outcomes focused and trying to achieve goals, as opposed to trying to see what we can fit into this already massively flawed system that we all acknowledge could be significantly improved.
Thank you for that. I wanted to call out a comment in the chat by Cincy. You mentioned sort of thinking differently about assessment, and we have to stop measuring whether healthcare is successful with money, instead better health. On the topic, I'm going to go to Carrie in a second, but on the topic of magical wands, my comment sort of is framed by the fact that I'm a full professor in a municipal health system. You talked a lot about involvement in who's doing the research, the targets. Research dissemination is also a huge challenge. Every journal requires different formats. There's a secret sauce to each of them. If you had another magic wand specifically focused on dissemination, what would you do?
What a great question. I think I would, we have adopted a paper structure, how we write papers, which is somewhat universal and very bizarre. If I was designing it from scratch, it is not the way I would do it. It focuses on an ability to let the same person who's writing the rest of the paper write the introduction, which means that they can cherry pick what papers and what citations they're going to pick to set up their issue. We then let them write the methods, when really the methods should have been written long ago, probably when the grant was submitted, and that's what should be submitted. Then we let them write up the results, and the results, again, are going to be pitched for positive, because that's how we get papers published. And we also allow them to change the methods almost in retrospect in order to achieve that. And then they get to write up the discussion and conclusion, where we don't want them to really talk about what this means, because we never want them to overstep the results, but we do want them to talk what it means. And of course, every paper ends with the same one. Of course, the next step is you need to continue funding my work, and so I can take the next step. In an ideal world, we would be better as scientists. I think scientists in general are too often only comfortable talking about the work that they've done with their own two hands. And so when you go to a scientific talk, it is, let me get as granular as possible to talk about my research and why my thing is important. And no one's research with their own two hands is ever understood in the context of what it means for health and even what else is going on in that area. I wish we were all better about truly in an introduction talking about why should I care about this? Why should I, why is this important? And let me not cherry pick, but really give you a full flavor of what do we know about this topic? What do we not know about this topic? And how am I going to fill in that gap? The methods, as I said before, should be just a standard format that should have been approved at the time that the project was approved, likely at the funding mechanism. The results should be just the results. Like we should have, a standard table mechanism of this is what you should know. Did we meet what we thought? Did the hypothesis succeed or not? Why should we care? And then a discussion. I don't have a problem with, talking about what this means, but I'd almost rather it handed to another person. Let another person or group talk about why should we care about this? Is this really important to groundbreaking or not? Is this work that we should continue? It should be a collective process. And maybe that should be the journal's contribution. I just wrote an editorial on a paper that was published by JAMA Pediatrics, where they had in the past, they had tried to do research in the past to get adolescents who were heavily obese or with really heavy obesity to change their behavior through meal replacement therapy. In other words, they paid for all the meals for an adolescent for an entire year, pre-made, and it didn't work. And so they went back and they conducted another randomized controlled trial where that now became the control group. But now that the intervention group was, we're going to not only do meal replacement therapy, we'll also pay the adolescents money if they lose weight. And it worked. They lost like 2-3%, statistically significant. And my editorial basically, which I wish was the actual discussion of the paper, was I can tell you why this is important. I can tell you how hard it is to do behavioral change. It's massively important that these researchers got funded. And this is typically when I would tell you that that now this is positive work. We should figure out how to implement it. We should figure out how to do more funding this area. But I don't have the heart or the strength anymore because it's never going to be implemented. We are never going to pay for all adolescents to have their meals done. We are never going to pay them on top of it. We can't get this into clinics. We can't make this safe. And these days, there's another thing to try, which is, of course, a lot of the new drugs that are coming down the pike. And so it was that I think this is really good research, but I hope I never have to read another paper like this again. And to their credit, I got an email from one of the authors saying like, oh, thank you for writing that. We actually discussed it amongst ourselves. If we had, would we still do this study? They applied for the grant funding 8-9 years ago. It's like, would we even do this study today? Of course not, but we have to publish it because we got the funding so long ago. We should have the courage to say so, though, in the paper, in the dissemination, to say, like, obesity is a massive problem. These were our old tools. Look how hard this is. And they finally succeeded. More power to them. But we've got to do better, and we have to do better now, and we should not fund this kind of work in the future.
Thank you for that example. Carrie.
Well, I think this follows on nicely. So you mentioned that a lot of our work is not particularly flashy. Let's say that study was done with whatever drug now that we've got. It worked beautifully. How would you recommend a high yield communication strategy be implemented once they've got the data?
That, I think, and again, I'm going to give you only my top of mind thoughts. This is when I would love more time to really develop a strategy. But I think we have to get better at, about talking about this. These are miracle drugs. These are absolute game changers, which I think have the potential to truly change how we look at the prevention and also perhaps fixing of what we have been screaming about is a major problem in healthcare. What do we need to fix in order for that to happen? One, that the price of these drugs have got to come down. So we've got to start focusing on that immediately. That yes, they're going to have to recoup, their investment and everything else, but we need to work towards approving more of these as quickly as possible to get competition into play to start bringing the price down. The second is we've got to start thinking about how would we change their actual use in the healthcare system in order to make things better. It's going to be really hard right now to turn the tide of how they're being used right now, which is to combat people who have had long-term obesity. There aren't enough of these drugs out there right now. It's a problem. People are getting demoralized because even if they can afford them, even if they can get a prescription, they can't fill the prescription. They're not using them the way that they are going to be used. We also have to start talking immediately about how if we're going to use them in this way, that they need to be used chronically, and that we have to be accepting of that. Just as you might be on a statin for the rest of your life, you might be on these types of drugs for the rest of your life. They can make a massive difference, and good things sometimes cost money. I also think if I was really trying to pitch it, I'd start talking about potential future. Maybe we should be thinking about how do we prevent obesity, coming up with criteria for maybe there's a population of people or adolescents even who are trending, or teens or young adults who are trending towards obesity, where if we can catch them right now, maybe they won't have a set point which gets 30, 40 pounds raised. And if we treat them differently right now, maybe we can prevent that and they don't need to be on these drugs long term. Maybe this is the research we'll be funding. Maybe this is, how we should be doing it. But we don't have that.
Yeah, and that's what I was hoping to hear about, just the overarching sort of, how does AHRQ promote that?
Sorry. I was thinking about how, okay.
That was beautiful.
Okay, well, I think how would I promote it is like innovative ideas, thoughts, like this is, maybe like, again, it's not just about saying yes, it's sometimes about saying no. It's sometimes not just about talking about benefits, it's talking about harms. It's not that I don't want to fund work into obesity research, but let's not keep funding behavioral interventions that are not implementable, not translatable, not scalable, not doable, even if they'll work as an example. Let's focus on research that is going to be implementable and translatable. And if there are other better options that exist, let's focus on those.
Thank you. Time is flying. We've about 5 minutes left. I'm going to turn it to our virtual participant, Liz, then Sunil, and then if we have time, back to Cincy. So Liz, you're up next.
Thank you. I just wanted to get your thoughts, very thoughtful comments on the challenges of implementation and adoption and thinking about research and opportunities for collaboration. I would appreciate your thoughts on the promise of implementation science as sort of a category of work, and also operations research. Doing more to think about combining health services methods with implementation science and even operations. Those are the folks that actually at the end of the day have to deliver a service. Would love your thoughts on that.
I'm going to apologize because I'm not sure I got all of that. Does someone here think that they did, or should I just ask for repeat? Okay, I might need you to repeat that. Unfortunately, the internet just sort of cut out, so I didn't get your entire question. Can I get you to ask it again?
Sure. Can you hear me? Okay.
Liz, it's coming in and out. You can also put it into the chat, but try one more time. Go ahead.
Okay, I'm not sure why it's coming in and out, but I'm just wondering if you could talk about the possibility of more collaboration with implementation science researchers and operations researchers who are really thinking about the challenges that you so thoughtfully have addressed about adoption and implementation. Did you get that?
Yes, and you know what? It's funny you bring up this exact question because we have Academy Health on 3 sort of core meetings a year. One is ARM, which is clearly our flagship meeting. Our second is Health Data Palooza, and the third is Dissemination and Implementation Science meeting. The fact that we have a separate meeting for dissemination implementation science is like really pointing to the fact this is so siloed. That still that feels separate and different from Academy Health, the ARM, which is really health services research. While I'm thrilled that we have those, obviously we all need to be talking to each other. And we need to have implementation scientists. I think, again, the way that we fund science is we fund the observational studies separately from the interventional studies, separately from the implementation science study, which has nothing to do with dissemination. And so we incentivize all of these people to focus on their niche without ever saying, how do we get all of them to work together so that the work that we're developing will then be implementable and then can be disseminated and then can be acted upon. We got to bring everyone together. We got to find better ways to do that. I would argue that funding is one good way to do so, because if you had a funding mechanism which required thinking the long term, but a long study with steps that have to be checked, but thinking all the way through to implementation science, even as you're beginning the study, would probably have a much greater chance of succeeding in a shorter period of time and achieving true implementation.
Thank you. Sunil, the last question or comment is yours.
Thanks for really wonderful, thought-provoking comments. And as an implementation scientist myself, I wholeheartedly agree. And thank you for your support of the D&I conference. I also couldn't agree more with your comments about judging our science by the impact it has on patient care. I work with a lot of research trainees, whether postdocs or junior faculty, and for various reasons, people often start with the observational research. The data are accessible, it's cheaper, and maybe it's appropriate to the career stage. I would love your thoughts on how we can build a pipeline of investigators, recognizing they often have to start with the observational work, yet need to get to the impact on patient care. There may be roles that a professional society can play, like Academy Health, or a funder could play, or academic institutions.
Can I say all of those?
Please.
Because I think you're exactly right. First of all, there is a role for observational research. It is hypothesis generating. It is how we make those associative connections that we can then say, okay, maybe this is something we need to intervene upon. Maybe we need to try to work in this area. I think the problem is that that we keep doing a lot of it over and over and over again. We just find bigger and flashier ways to do it. I have a new, I know that in observational research that, increased salt intake is associated with badness. Well, now I can do a bigger cohort study. Now I can do a longer cohort study. Now I can do it. Now I can do a meta-analysis where I combine all of the observational studies together and keep getting the same results that I've gotten over and over and over again. When we actually try to do randomized controlled trials, we don't see it bear out. We've seen this. I mean, nutrition is easy to pick on, but we've seen it with cholesterol consumption. We've seen it with where you can find the links. Oh, you have high cholesterol, therefore, that's associated with badness. Then when we actually did studies to say, well, does eating cholesterol actually, it turns out no. But, for years and years and years, just doing observational studies, we kept focusing on don't eat eggs or eat egg white omelets, which are a crime against nature. Instead of saying, okay, you know what? Lots of people may need to be on drugs for this because their bodies are producing more of the cholesterol than they're consuming. Now, I don't propose to have the exact answer, but I do think that at some point we need to never fund something which has been done over and over and over again. That observation, don't fund it. Like, say no. In the same way, don't publish it. In the same way, don't cover it. We have to be able to say at some point, like, we have enough observational data. It is time for us to start fixing the problem and time to start incentivizing science to fix the problem. And again, if I was pitching for my magic wand again, if we had a plan of here's a problem, how are we going to attack it? Let's first do the observational work to see where the key impacts might be, and then move on to the interventional work, and then figure out how we're going to implement it and have that be part of a whole structure, we'd avoid that. But as long as we're willing to, incentivize the funding, incentivize the publication, incentivize the promotion, incentivize the publication, and then in the media, we're going to have another study that says if you eat salt, you're going to die, which is going to be front page news no matter how many times people read that study, we will continue to see the same results in the conduct of science. There are better ways, and I think funding can play a part of that.
Thank you so much. And with that, this portion of the session, we are out of time. I'd like to thank Dr. Carroll for joining us. Look forward to seeing.
Thank you. And I just, this should be a floor, not a ceiling. I think these conversations are super important. I look forward to Academy Health. Thank you so much for having me. It's a real honor.
Thank you. So we are going to take a 15-minute break. We will be resuming at 3:30. See you soon. like to invite everyone to take their seats. Virtual participants, just a reminder, we're going to be starting in 1 minute. Wow, everyone got so quiet. Wow. I mean, listen. I mean, if boss says 3:30, 3:30 it is. All right. Just ask everyone to make it back to your seats. What a rich discussion we've had so far. Let's see here. Okay. Welcome back. That was a quick break, and I know there was lots of conversation that was happening, which I hope continues in the future. It's my pleasure to now introduce Dr. Arlene Bierman, who is AHRQ's Chief Strategy Officer. Dr. Bierman gave us an update to the NAC members last July. Can't believe it was 1 year ago at July's NAC meeting about the AHRQ's aging initiatives. We're glad that she's here returning to provide new updates and information on the age-friendly healthcare system strategic plan. The floor is yours.
Hi, so I'm really, really happy to be here today. And I really look forward. I'm going to make this a bit more interactive because I really want to hear from you. So we've done a lot in the last year, and thanks to the NAC for the feedback they gave us a year ago. But and we've actually incorporated a lot of the feedback and a lot of our, engagement with stakeholders into a strategic plan. And so our vision is that all Americans receive high quality, person-centered care based in primary care that optimizes health, functional status, and well-being as they age and advances health equity. And the problem, which we all know, is that the US population is aging and the health system is ill-prepared to meet the needs of older adults. And we know that people get fragmented care, suboptimal quality of care, and it really leads to adverse health outcomes, suboptimal outcomes, as well as increased costs because of the care that we deliver. And so the solution is to re-engineer the healthcare delivery system so that care transformation optimizes health outcomes, functional sustainability of Medicare and Medicaid to really address these issues. So I think we have a collective failure to act, and there's multiple reasons for that. And I want to go through it because I think if we're going to make progress, we have to really address some of these barriers. I think one is that there's nihilism. People just throw up their hands. It's a big problem. What can we do about it? I also do think there's a lot of ageism. There's been a lot of that in the media, but that biases the care or the priority we give to improving care for older adults. And then a lot of avoidance and denial. And so I was thinking about like the pandemic. We knew pandemics were coming. We didn't do anything. And as I was preparing, I remembered an editorial I wrote in 2012 for PLOS Medicine that said averting an impending storm and saying that the population was aging, the health systems weren't ready, and that there was a lot we could do to start getting prepared. And, 12 years later, we haven't really done any of that. The other thing is I think there's a lack of awareness of existing evidence. We actually have a lot of, controlled trials evidence about what works and models of care. We have the GRACE model that supports low-income elders in primary care settings. We have Capable that help people, stay in their homes. We have the PACE model. Mary Tinetti's work on patient priority care. We know how to elicit patients' priorities and align care with their goals. None of this is scalable. It all depends on resources from the research, and there's been so many barriers to, implementing that across the system. And then there's competing priorities. Yes, aging is a priority, so is maternal health. There's so many, priorities. So how do we just get this to be included as one of them? The misaligned financial incentives, the way we pay for care just makes it really challenging to do this right. And then a lot of concerns about cost, like, cost is always an issue. But the reality is that there's a lot of return on investment from doing this right. First of all, we know there's a lot of waste in the healthcare system. There's a lot of duplication of services. We pay for costly outcomes. And so that there is value. And maybe some of the move to value-based payments can help. The other thing, there was a really nice econometric analysis that was published in Nature Aging by Scott. And what he found was that if you could extend active life expectancies by 1 year, so 1 more year of your life without disability, it's worth $38 trillion a year to the US economy. And we can do that by really focusing more on prevention and improving care, chronic disease management and improving care outcomes. So how can AHRQ do this? These are AHRQ's levers. This is what AHRQ can do. So we have a convening function, including learning communities. I'll talk a little bit about this a little bit more later, but we have a national collaborative on scaling and spreading person-centered care planning. We fund health services research. We just had a great discussion about that. We have the Person-Centered Outcomes Trust Fund, funding that funds dissemination and implementation, clinical decision support and training. That's all relevant to improving care of older adults. There's a typo on here. It's tools and resources for practice improvement and research that we provide, and also data and analytics. So last April, I think that right before I had talked, with the NAC before, we held a roundtable on optimizing health and function as we age, and we put out the roundtable report. And interested, listening to Dr. Carroll, so much, there's a nice section in there about how academic incentives are one of the big barriers to moving a lot of this work forward, as well as the need to use different methods and do research differently to get the evidence we need to really change care. And so, I encourage you all, we sent it out to you beforehand to just take a look at that report. Next slide. Oh, sorry. I did a webinar this week where I had to see the slide 2 days ago. Anyway, so we had some really interesting discussions at that roundtable. One was that, there's a big discussion. Is it policy that we have to influence, or do we have to align payment? And, you can't do one without the other. And then a real big discussion around, we really need culture change in the way we approach care, the way we interface with patients and communities. And we also need the evidence. So we need the evidence for what works both clinically, but also in terms of what models of care work best, as well as what works best in terms of, implementing them. So if you think about all those things, the sweet spot where those aligned is really small. And that's why I think we have such a challenge in really making sustainable change. And I just want to point this out to you. The NASM did a report on a roadmap for healthy longevity, and there's a chapter in there on what health systems should do. So it's much broader. It's a multi-sectoral report. But I encourage you to take a look at the chapter on health systems, because they basically said that we need to shift healthcare systems to focus on healthy longevity, and actions to be taken include health systems in concert with communities and the people they serve should adopt affordable, accessible, and culturally appropriate models. Government should develop plans for aligning healthcare payment and reimbursement systems, and that healthcare systems, we need meaningful measures. That's one of our challenges. We should measure care outcomes based on patients' goals, preferences, and use patient-reported outcomes. So I'm going to make this interactive because we've all been sitting all afternoon, and I'm going to just say what we want overall. We've developed 5 goals for the strategic plan, and I'm going to do one at a time, and we could take a few minutes of discussion for each one, and then at the end, hopefully we have some time to put it all together. So one of the questions for the NAC, how can AHRQ have a meaningful impact with respect to research, dissemination, and implementation of evidence to improve the organization and delivery of healthcare, to improve outcomes for aging populations? What ongoing and planned related work should we be aware of to avoid duplication and maximize synergies. One of the things I've been doing over the last year is really reaching out to federal partners, foundations, community organizations, professional societies. And there's a lot of good work going out there. We're very siloed. And if somehow we could align this work and we could all focus on our strength, I think we could have more impact. And what are the opportunities for collaboration and partnership so that AHRQ could maximize its impact? Next slide. Oh, I did it again. I'm sorry. And so anyway, embarrassing. Anyway, goal 1 is really to fund research. And, that's our key mission. But to support health system transformation by funding research to develop, implement, evaluate, and scale person-centered models of care. And some of the strategies under that goal, we recently issued a special emphasis notice to communicate and alert the field for our, interest in receiving applications in this area. So I encourage you to share it with people who might be interested in applying. We're also going through our notices of funding opportunities and program announcements to, sort of mainstream aging as a priority population. And I'll give you one example. So for the diagnostic centers of excellence, we included language about the unique challenges of accurate diagnosis in older people because it is complicated. And there are actually, we have funded some of those centers are doing some related work, which is really important. I think there's a lot of digital health solutions, and our digital health portfolio has quite a few applications already that are really advancing our ability to improve care. So, and also our budget proposals, we do write, we might not get the funding we want from the Hill, but we do write budget proposals to say what we could do if we were funded. Our evidence syntheses are key for knowing, what works, what doesn't, evidence maps. AHRQ actually did the first evidence review on social isolation before, and now it's, gaining a lot of traction. So sometimes we're ahead of the curve, just laying out where is the field and what do we know and what don't we know. We've recently done an evidence map for our sister agency, the Agency for Community Living, on home and community-based services. And what do we know about effectiveness in that arena? We do conduct intramural research to advance the world, and also really letting people know about AHRQ's databases that are really a rich source to do some of this research. So I'm going to stop there. And any comments on the research piece of it?
Yeah, I have a comment. So right now, over half the Medicare beneficiaries in the country are cared for through MA plans. Probably 70 to 80% of Medicaid beneficiaries are cared for through managed care plans. You guys fund research that's done by academicians in medical schools who often have no relationship with the health plans that deliver the care. I think you need to kind of close that gap somehow. There needs to be, either through CMS or through state Medicaid agencies, requirements that bring these parties together, because you can't do the work in isolation and you can't get the health plans to translate this work if someone's writing papers and the health plans either don't read it or don't use it.
Thank you, Mario. Are there other comments? Mason.
I would add on your topic of the roadmap for healthy longevity, a model you might look into, or AHRQ might, is the tribal healthcare system. So, tribes operate large, robust healthcare systems that integrate programs for our aging elders. And it's all integrated through our clinics, whether it be public health initiatives, healthy aging, diabetes care, or getting them the services they need. Could be a good model to kind of look at and see how that could be applied elsewhere and on other levels of government.
Thank you, Mason. Sunil.
I have a broader question to help shape the focus of our discussion. As we talk about a research portfolio related to aging, I'd really like to just get clarification on what that means. On this slide, it refers to older adults. On your previous slide, it referred to population as it ages, suggesting they may not yet be elderly. Maybe people like me who are concerned about maintaining functional status. Yet, as we have more and more people with multiple chronic conditions or people from populations that experience more social risk factors who may experience weathering, as I saw it reported in one of our pre-reading, there's or people who have advanced medical conditions like transplantation or things where we're seeing people in their 40s and 50s experience a lot of the syndromes that we would typically associate with aging. So I'm wondering, for the scope of this discussion, are we including all those populations who experience aging-related syndromes, or specifically on a group of individuals beyond a certain age?
So Sunil, that's a great question. And I think we do have to take a life course for approach. And I think that, fixing things for, AHRQ has had a focus on multiple chronic conditions as well as older adults. And I think the things we need to fix care, is translatable across all of these populations. And I agree that there is, in terms of health inequities, aging and multiple chronic conditions are a health equity issue because people do age faster, have a higher burden of illness, and, and we need to intervene. Also, if you're going to improve people's outcomes across their aging, in the packet, I sent some pre-read materials. We really like the continuum of, a lot of the focus has been on high cost, high needs populations. And yes, that's important, but if we don't go further back and intervene earlier, we're going to always be replacing those people, even if we do a better job of managing them. So we actually stratify the population. I know a lot of health plans use rising risk. So, those are people who have, diabetes and COPD, but they're stable, but they're just one event away. So, so we need to figure out how to intervene earlier. And then those that are at risk, one of the reasons I call the multiple chronic conditions a stealth syndemic, right? It's a syndemic is when you have, multiple diseases, and multiple factors like contributing to each other. And that's what we have, because those people have all the risk factors for chronic disease are the same. So that strata of the population is at risk. So ideally, you would have a health system or primary care network that would risk stratify and identify appropriate interventions to that, for whatever is appropriate.
Thank you for that. I just want to make sure Michael, and then we'll go to Carrie.
A couple of quick suggestions and a question. And the suggestion is there's been a lot of assumption sometimes that the elderly cannot engage in shared decision-making. And there's been some research that says if you do it right, that they can. And particularly as we go into technological age, I think we have to fund research that looks at that, understanding that someone who's 65 may have been using the internet for 30 years. And someone who's 85 is different, both in cognitive capacities and how long they were using it. So we tend to sort of lump folks together, but certainly the people who tend to get sick, it turns out when you're older, you have a greater chance of dying and often getting sick. So even with compression of morbidity. So I would encourage that. The second part though is I'm a little confused, I have to admit, as a new member. So I listened to your presentation and I go, wow, this is really thoughtful and wonderful. And where I'm confused is we have the National Institute on Aging, we have the National Academy of Medicine, we have all sorts of people putting out white papers and, White House task forces. To what extent do all these other federal groups look at AHRQ and its mission and say, you know what, you should be the lead on this, let's get past our silos, et cetera?
So that's a great question. And that's what I was saying is, one of our goals is sort of that synergy. And we've been partnering with our federal agencies a lot. And we talk closely with NIA. They develop, a lot of the interventions and we can implement them. What we do is, and even their D&I work is much more theoretical, where we're more applied, where we really want to, work with the health systems and make things different. And I think, you know, this administration has been fantastic in terms of bringing together people across the department and across the administration. So there's a very active working group that's actually organized by ACL and ASPE on integrating health and social care. And everybody's involved in that, CDC, CMS, HRSA, AHRQ, and we all have a unique contribution. And AHRQ's contribution is that connection to the health system. And how do we bring the health system into that? And even AHRQ, you know, I served on the White House Interagency Committee on Social Determinants of Health that put out a playbook in the last year on addressing that. But AHRQ was able to bring, how do you connect all this work? They brought together education and transportation and housing, but the health system has to fit in there too. So I think AHRQ does have a very unique role, and that, yeah, we shouldn't try to do it all. We need to know what other people are doing and what's our sweet spot. Like, what can we do that will make a difference?
So real quickly, that Aaron mentioned publicity for HSR. So you have Judy Graham of KFF Health News, who has a grant to write about elder issues and has picked up with the Washington Post and folks like that. So I would suggest that when you say AHRQ and unique role, that you know, sometimes boil the horn and make sure folks understand that.
We would appreciate your help in doing that.
Thank you. We're going to go to Carrie, and then I know, Arlene, you have a bunch of other goals that I want to make sure you get to, but please go ahead, Carrie.
Okay, I'll be quick. One of the things we noticed on our campus is less than 5% of all of our studies enroll people over 65. And so I wonder if you could comment on strategies to get older folks enrolled. I realize there's a focus on lifespan, but we got to get that part of the span in as well in our studies.
Yeah, no, I think it's true. So I agree. And, you know, I mean, part of it is the bias. And we also, you know, we exclude people from trials who have disabilities, who have multiple, you know, conditions, who have, you know, complex social factors. And then we don't have evidence for what works in the real world. So I think NIA is doing a big push on trying to, you know, get more representative populations in their trials. But also I think, you know, for AHRQ, we can do pragmatic trials and really build real world evidence to get the evidence for what works, you know, in a more generalizable population.
Mm-hmm. Thank you for that. If you wouldn't mind going over your other goals so that folks can react to it.
So the next goal is disseminate and implement evidence. You know, there's been, you know, announcement about AHRQ's new extension service. I would hope some of the states would use this as an opportunity to address some of these issues. And I'm going to talk a little bit about our person-centered care planning initiative, which I'm very excited about. So both Mason and Michael. So this is funded through the PCOR Trust Fund. We have a grant through our Action 4 network to OHSU as the lead for that. But what we're doing is basically we have two tables. We have health system, you know, leadership table, a round table, and we have people who are, you know, health system leaders, Medicaid medical directors, state health departments, payers, professional societies. What levers, you know, like sort of the early adopters, people who get this, what could your systems do to make this work? And then we have a learning community of innovators, you know, so to learn from each other and accelerate learning. And we're going to hold a summit next spring, bringing these two groups together to see if we could come up with some solutions. But we have actually, we have the tribal health systems are represented on both of those tables. And, you know, we have a lot to learn from them. And then, you know, the idea is to engage, you know, care plans that respect what people's goals and priorities are and do that shared decision making. But it's really hard to do now, given the way we pay for care and sort of the culture in our systems. So the e-care plan for multiple chronic conditions is something I still do a little, I'm a recovering academic, but I still have to do a little bit of my own research. And so I've been working in partnership with NIDDK to develop, it's a two smart on fire apps. It's a clinician facing and clinician and caregiver facing app and a patient facing app. a patient caregiver, and they can talk to each other, and they can aggregate data from multiple EHRs, but also could collect social needs, goals, functional status. So we're developing, and we've been sponsored by HL7 and actually developed interoperable data standards to do this. So we're trying to contribute to the research for people to be able to have some of these digital solutions. We've been engaging with learning health systems in states, engage patients, families, caregivers. We realize that this has to be a partnership. And also, within the P-Core Trust Fund, there's a lot of opportunity to use those funds to include some of these types of questions. Maybe I'll go through a few of them because we had such a long discussion there, and then we could put it all together. So, and then AHRQ's training the workforce to do this research. And so to support training and mentoring of health services researchers with expertise in improving care delivery for older adults. And so we've been getting out the word to, the health services researchers who focus on these questions, that we do have the training, dissertation, and career development awards. We have the P30 grants to learning health systems. All of these are opportunities to do some of this work. And we also host fellows at AHRQ who work with us on developing some of this work. And then goal 4 is to expand and create synergies across AHRQ's portfolio. So no surprises, AHRQ could be siloed too. And sometimes we don't know what people are doing across AHRQ or in other centers. So our goal is to expand and create synergies across AHRQ's portfolio to support health system transformation, et cetera. And so what we've done is we've created a cross-aging working group, which has been great because, CFAC is doing, analyses, on Medicare payments, and patient safety is doing work on diagnostic safety, and CEPI is doing stuff on urinary incontinence and improving management, and so that we all have a chance to share across the agency and see how the whole could be more than the sum of its parts. We're tracking and collating AHRQ's work in this area. We're in the process of designing an AHRQ webpage to aggregate these resources. We really want to widely communicate AHRQ's aging-related work and initiatives. So yes, Michael, we would love your help on how to do that. That's not my skill set. But we had a blog recently on our aging work, and hopefully we'll be doing a little bit more writing to communicate that. And we really want to educate, our funders on the real opportunities in this work. And I think also the link to the sustainability of Medicare and Medicaid. We pay for so much care that's inefficient or low value, and how do we, transform some of that to do better care? And then finally, goal 5 is really, also this came up earlier before, was to develop strong federal health system, public health, and private sector partnerships to transform healthcare delivery to meet the needs of our population. So I mentioned we're working with our federal partners, on integrating health and social care, strengthening primary care, addressing the social determinants of health. We contributed the first ever report to Congress was mandated under the Affordable Care Act on aging, and it was a framework to develop a national plan on aging. A lot of states now have multi-sector plans on aging, and there's a real great potential to do that nationally. And partner with foundations and community-based organizations if there's people that we should be talking to, reaching out to. I could give a shout out to the Hartford Foundation, which is doing the 4 M's and working on changing culture in hospitals across the nation related to this. The SCAN Foundation, who has been supporting a lot of the states in developing their multi-sector plans on aging. So I think there's a lot of opportunity to do more, public-private and community partnerships. And then we also want to increase awareness of all our data tools, resources, and research findings by our partners. So that's it. And I'll just put up the questions.
Absolutely. I always love that you, I always appreciate that you end your comments with that photo of nature, right? And we trailblaze our path. Thank you for outlining your robust 5 goals. I'd like to open it up to comments. I see Jaji has his hand up.
I have a question here for number 5, for the partnership. Do you have any with the states? The reason for different states? The reason I ask is that more than 20 states, I believe, have all payers claims data, which are extremely valuable. For a payer to do business in a state like Texas, you have to submit all your claims data to a centralized entity. They have all the cost information, the outcome, pretty much everything. That's extremely valuable data set. I do not know if AHRQ has similar data besides Medicare.
Oh, yeah. So AHRQ is, I don't know if somebody from AHRQ can speak more to this, but AHRQ has been working on developing an all-payer database and linking to some of those resources. But yeah, I think that's key. That's a little bit beyond what, you know, I don't know the current status of that work, but AHRQ is very, very interested in that work.
Shajay, we've had a synthetic database that was done in partnership with ASPE, and we continue a project to develop a real all payers database, because although states have all payer databases, they actually have holes in it because there are certain payers that are exempted from contributing to those. And within the federal government, we have access to those data, so we can actually fill those holes for those states who have all payer systems and use that to actually create synthetic all payers data for states that are too small or can't afford to run their own all payer systems. And as I said before, most states are where health policy actually gets made and where the rubber hits the road. So this is, as you say, an important aspect of trying to provide the data and information that's required to make better healthcare policy and payment policy and a whole variety of other things.
Bob, thanks for sharing that. What are those synthetic databases called, or that initiative called?
Oh, well, the initial synthetic database, which can be used actually also for training purposes and educational purposes, is I know it's called the all-payer health system, synthetic all-payer health system, I think is what it is. Let me turn to Melissa. Do you remember the exact title? I don't remember the
I didn't mean to put either of you on the spot. I just know it's such a robust thing of the million other things that AHRQ does, right?
There are actually two databases that we're talking about. Sorry. There are actually two different databases. So one is the all-payer claims database, which right now is a pilot project that we are hoping to kick off in the fall, roughly. So it's to build off on work already done by ASPE in past years and in collaboration with the All-Payer Data Council. So that's a separate project. In addition to that, about 2 years ago, we created a synthetic database. I believe it's posted on our website as a research database. And so if folks just go to our website and just sort of type in synthetic data, it should pop up there. And I believe there's like a form you have to fill out, and then you can get access to that data.
Thank you for that. There's just so many fantastic resources, right? Hard to remember them all. Thank you for those comments. We're going to go to Joan, then Sharon, and then Mary Beth. Joan, you're up.
Thank you. What a great report out. Thank you so much. Just a few things that come to mind. So I also had the opportunity to work in a really large company, and I learned very quickly that the first thing I had to do when I wanted to entertain a new project was learn how many other parts of my company were already working on that and maybe didn't know it. And so when you think about that for a company or a government department like AHRQ, and then superimpose that on the state and the national level, my question is around creating some sort of, and it's a tall order, but some sort of a database where anybody who wants to work on a project can see who's working on it where, just so that we aren't duplicating without the opportunity for synergy to occur. Maybe we're already working on that, but it seems to me that as a national department, AHRQ, we could be thinking about that. And I don't know if there's any AI opportunities to think about how that could work. But my second thing is, if this doesn't already exist, there is so much information to disseminate across this country. And again, think back to each place that each of us works and how little that gets disseminated gets really absorbed in a way that's meaningful or usable. What are the opportunities to think about a standardized dissemination process for easy to understand stuff and a standardized process for more complex things that take more to get? Like, what if there was a national path that others could participate in if they wanted to? Standardization, in my mind, might make it easier. And I'll stop.
Joan, thanks for your comments. I'm going to turn the mic to Sharon and then Mary Beth.
Sure. This is really just more of a comment when you're thinking about cross collaboration across AHRQ. The Patient Safety Organization program has the potential to do some really, I think, interesting, innovative programs. I don't really know if they're there yet. I know that there's groups outside of AHRQ that do things like national safe tables where you can really dig into specific things and have really good conversations. So as you're disseminating and tools and programs, like figuring out how you can have really good, robust conversations under the protections of the Patient Safety Act that come through the PSS.
Mary Beth, the floor is yours.
Thank you. This was great. I think I'm very excited about the e-care plan from a couple perspectives. And so a little bit personal. A 94-year-old mother-in-law lives with me, and she's lived with me for the last 27 years. And English is not her first language. And so one of the things that excites me about the e-care plan is that she would have control of her data. So while she gets healthcare at a facility, she has been emergently admitted to B, C, and D hospital over the last year. And each time the care that she has received at a hospital or primary site gets repeated because we don't have access to, even though we agree to provide it, they wish to redo all of the care. And I think some of it, sadly, is because of reimbursement for the services they're able to provide her at those other facilities. So one of the things that I would encourage you to think about in that care plan is the transferability of that data across different facilities as older individuals get admitted in multiple hospitals for different events, especially when they have multiple chronic conditions.
So it actually does that. And it gives the patient and caregiver control of their data. And you could, either they could use it, independently, or they could share it with their provider, or hopefully their provider has it too. But what it will do is pull in data from multiple EHRs. But what's nice is now that people have, 5 portals because they're going all over the place, it's impossible to visualize or synthesize. What this does, it'll aggregates the data automatically using data standards, so that if you have, it'll have all your medications, all your tests, all your problem lists, even your goals from all these places in one place. And then you could share it with with those facilities. And, one of the limitations, so this is a proof of concept. This is something I couldn't have done. I'm a recovering academic in an academic setting because it was high risk, high reward. But we've been sponsored by HL7, and we're actually publishing in the next month in July. It's just been approved, our implementation guide with these data standards that anybody could use. So everything we won't have is open source in the public domain. High Tech, which advises ONC, has recommended, based in part on our architecture, that the next round USCDI version 5, which is the requirements for EHR, include this as not mandated, but include this as a data class. The kind of data we collect for care planning, which will be a big deal. We don't know what ONC is going to decide, but we'll know in the next month or two. So, but I think one of the limitations, honestly, of what we've done, so we've done it in English. We haven't culturally adapted it. And I think there's a lot of potential for other people to take that and translate it or adapt it to other languages and cultures.
No, thank you. And I think an opportunity with it too is that the organization or the other hospitals that they go to accept the data that's on that e-care plan for the patients.
We're going to go to, thank you for that. We're going to go to Al and then Cincy.
Thank you. And so
I've been sitting here quietly, and I have a lot of thoughts, but as we look at the healthcare model, I'm a pharmacist by background, and so I'm coming to this from a pharmacist perspective. I hear a lot about the health system, but a lot of delivery models, especially for chronic care, are going to a model outside of that healthcare system. And so as you look at opportunities for collaboration and partnerships moving forward, I know there are several states that are doing some amazing things with pharmacists that are reaching out, as we talk about health disparities and inequity, are reaching out through these pharmacy models to do so. So I don't know if that's been considered already, and if it has, then great. I'd love to continue to contribute to that in any way I can. If not, I think it is something we definitely need to consider moving forward.
No, I would love your idea. So, you know, what we've done was develop the data standards and really a proof of concept in the prototype apps. But actually, we've built on what other people were doing who've been generous. And one of the first ones is a pharmacist e-care plan, Shelley Spears. And so the patient could indicate whoever they want to be on their team. So if they want to engage the pharmacist as part of their care team, they can do that. But there's probably a lot of work that could be done to make it more useful.
Thanks for spotlighting that. Again, the time goes by fast. We've got about 5 minutes left. Cincy, the floor is yours, then Michael.
Hi, thank you so much for the presentation. One of the things that I feel could be really impactful for AHRQ to do in this space that it's kind of like in between some of the different strategic points that you have, is making the case more effectively on the issue of like health, going back to like Sunil's question, on the issue of healthy longevity. And everything that we know about, you know, all the chronic conditions that are happening to people earlier and earlier, to find ways to really effectively make the case of why we can't just have like, it's not geriatric care, it's, you know, and then you have your kidney specialist, and then you have your lung specialist, but that not only do you need like, and that's why the primary care center for it is so important, because you have people that they're not just trying to manage different portals, they're trying to manage different doctor's offices and phone numbers and, you know, and all the things. And that it needs to be pushed back. Like it can't be like, okay, I don't know, arbitrary day at age 50, you start worrying about it, right? It needs to be something that is a life course process and a life course system. And I think that because of the connection between information, data, research, and then how it connects with health systems, AHRQ is very uniquely positioned to be able to kind of make that case. And that's where you get to what we were hearing earlier about like, why should I care? Why does this matter? You know, and it makes a really big, you know, it can make a really big difference and people will identify with it.
Cincy, thanks for that. You know, your comments made me think about, you know, there are certain conditions that occur during pregnancy that then, you know, 20 years later show up in different ways as chronic conditions. And so again, you know, it's just building on that. How do we sort of extend that continuum? Michael.
Real quickly, when I heard Mary Beth's comment, I thought of a LinkedIn press release I saw yesterday about a company that's been in this space for a while that takes all of your medical records, collects it automatically from wherever it is, digitizes it, and organizes it. And when Alina was talking about the caregiver app, I mean, I've seen people who were doing that 5 years ago. And so you don't know they exist, and God knows they don't know you exist. And so I think that as we digitize medicine, right, at a pace, I'm not even talking about AI necessarily, but you all, I would suggest, need to set up a systemic outreach program, which we have help with, to go to some of the people who can track some of this and go, are we reinventing the wheel? And you know, before the pandemic, I've fooling around with some of this, with putting together the innovators, the researchers, and the policy people, all of which do not have connections to each other. And all of whom, like policy people, say, we ought to do X, and they don't even know that people are working on it. The people who are working on it don't know about the evidence that the health services researchers have generated that could prove that the thing works or doesn't work, and the same around. And so, if we're going to change care, I would recommend that AHRQ would be a perfect place to start to take advantage of setting up listening so each group knows what the other is doing, which could accelerate policy and frankly accelerate implementation.
Thank you. So with that, we are going to close this portion of the meeting. Thank you, Dr. Bierman, for your comments, and thank you everyone for the rich discussion. So we do not have any public comment today. And so we are going to take that time and add it to some of the rich discussion I know we're going to have around consumer experience. And so I'd like to invite our presenters that are in person to make their way. And I'll set up a few comments around where we've been, and then we'll leave it to our esteemed presenters on where we're going. So the NAC has held robust discussions about the CAPS program and potential opportunities to improve consumer-driven measures of experience and outcomes more broadly in July and November of last year. We dedicated multiple NAC meetings, to this topic. And overall, what we heard was that there was a lot of support for CAPS and efforts to build on success. And what was also clear is that there are opportunities to improve CAPS, whether it's including sort of more feedback from interested parties about the surveys, improving the response rates, and the need to find sort of new ways to collect patient experience, whether it's through different kinds of surveys or other methods to really get that information faster. And so with the change in leadership to both the Center for Quality Improvement and Patient Safety at AHRQ, as well as the CAPS program, AHRQ has a unique opportunity to bring fresh eyes and ideas to this capstone AHRQ program. AHRQ continues to expand stakeholder interactions and gather ideas about how to improve CAPS surveys. And with that said, I'm very excited to introduce our next panel. Each presenter comes with a very unique perspective, and we're going to hear from each of our 4 panelists. They've prepared some comments, and then we'll have the panelists sort of react to each other, and then I'll open up the floor for what I'm certain will be a very robust discussion. And so I'm going to introduce our panelists in order of presentation. I just want to confirm that they have been made panelists. I just want to make sure. Take a look. Looks like they're all here. Wonderful. So we have 4 wonderful panelists. The first is Dr. Cliff Gauss, who is the president and CEO of the National Association of ACOs and also served as one of AHRQ's directors. Welcome home, Cliff. We will then be followed by Mr. Danny Van Leeuwen, who is the founder of Health Hats, who will provide a unique vantage point from the patient perspective. We'll then move to Ms. Cynthia Bland, who is the Director of Statistics for RTI International. And then we'll round out the commentary from Dr. Dana Gelb-Safran, who's the President and CEO of the National Quality Forum. Both Dr. Gauss and Dr. Safran join us virtually. So I'd like to now turn the floor to Dr. Gauss. The floor is yours.
All right, thank you. Can you hear me?
We can hear you.
All right, terrific. So Bob and the NAC members, I want to thank you for this invitation and providing somewhat of a homecoming for me. I'm very sorry I'm unable to be there in person, but hopefully we can have a great dialogue here. The NAC was initially established as long ago as about 1990, I recollect, to gain that valuable insight to the broad needs in healthcare for health service research that would come from the Agency for Healthcare Policy and Research, AHRQ's predecessor. I'm not sure everyone knows that CAPS had its beginning when I was administrator of AHCPR in the years 1994 to 96. When I took the job and I hired Lisa Simpson as my deputy, we in the staff leadership decided to do a complete review of the agency's mission. And we learned that at that time, there was literally no voice for patients in the research priorities, the data, and there was virtually no knowledge about patient interactions with the healthcare system. So as part of the new strategy we developed, and as it evolved, the new priorities were set around patient research and a whole cluster of cooperative agreements, grants, and contracts were awarded with the proviso that they work together in developing the CAPS with the very best survey science at the time. CAPS initially, I think for many of you who know this, initially focused to help consumers select health plans. That's the reason the last three letters are Health Plan Survey, HPS. Those letters have evolved over the years to include many other venues for the surveys and many other questions for families and patients. Most importantly, the surveys have become an enormous voice for patients in how healthcare dollars are allocated and impacting the way healthcare providers and plans deliver their care. For some organizations, it literally makes a difference between whether they prosper or go broke. We started as a single government agency initiative, and that's become just a very significant interagency tool within HHS. The current consortium and support contractors manage a vast amount of work keeping the surveys current and unbiased. And I guess as any father would, I'm extraordinarily proud of those who followed me and have accomplished so much in the 30 years of CAPS. So kudos to you. What I want to do in my opening comments is give a little perspective about how CAPS fits into the part of healthcare that I now work in and our concerns. I'm CEO of the National Association of ACOs, representing over 400 ACOs, almost 9 million beneficiaries, and over 200,000 healthcare clinicians. Accountable care organizations, or ACOs, are groups of doctors and hospitals that voluntarily come together to work collaboratively with the goal of providing better patient care at lower costs. Now, patients are part of every ACO's governing board, and patient-centered care is at the cornerstone of an ACO's operation. NACO's mission is to improve population health, enhance patient experience, reduce costs to patients and taxpayers, support care teams, and advance healthcare quality and equity, all very complementary to AHRQ's. Most importantly, NACOS is driving the move to the much broader value-based care in all the sectors of healthcare. I'll talk a little bit about what that is in a minute, but I mean, and we also lead the Alliance for Value-Based Care with governing partners such as the AMA, AMGA, APG, and Premier. The move to value-based care outside of Medicare is astounding. 75% of the ACOs have contracts in value with payers. The move to those contracts marriage the goals of cost containment and patient quality across the United States is not going to diminish at all. I mean, it's going to just grow. It's prominently discussed in congressional circles. CMS devotes an enormous amount of energy to it. And I think that's the reason CAPS kind of will become more important than it ever has. And it still is the one source of really patient-provided quality measures that become embedded in almost every value-based care contract. Before I go into some comments and concerns about CAPS in that value-based care space, I need to say that every leader I speak with in every healthcare venue understand its value. That's not ever criticized. However, many launch into a diatribe about its shortcomings, how much they might despise it because it costs so much, and the complexity it brings to their operations. The CAPS for ACO survey was first launched in 2012 for 2 different models of ACOs. 7 measures were assessed using the new patient experience survey. There's 81 questions on that. And performance on CAPS surveys ultimately now determines the ACO savings, driving billions of dollars in bonus and penalties, and tens of billions, maybe hundreds of billions of dollars in the MA program. In 2023, ACOs are measured on 10 CAP measures. There are several concerns we consistently hear from our members, and the members, mind you, are hospitals and physicians working together. So one of the first ones is the timing between the experience and the survey. It's too long, and patients conflate the experiences with various providers, and it's not always accurate to the provider. If the provider is in an ACO, that's fine. If the patient conflates the experience with a provider outside of the ACO, we do not know that, and yet we are accountable for those measures. Survey language. Surveys often ask how patients rate their overall health. We think it might be more appropriate to ask if their provider supported or improved their health. Some questions also can be misinterpreted, I guess, and just don't reflect the care being given at the time that encounter occurred. And I'd like to say that with the advent of AI, what needs to be done is a much more exploration of open-ended question responses. And the AI is great at assimilating these, comparing them, interpreting them. And so as I get a little bit further here, and I'll kind of about three more minutes, I'll talk about some things that I think AHRQ could do to improve the whole patient experience. The future directions I think that we should go are limiting the amount of time that it requires the patients to take the survey. And you'll see what I'm meaning by that in a minute. And not introduce any additional burden for the providers. And then lastly, be timely to the precise encounter that is being assessed. ACOs have actually found that it's called Net Promoter Score, NPSs, and some of you in survey science probably know better than what that means than I do, that is more closely related to patient satisfaction, loyalty, and referrals. And it's actually a metric that's widely used across the economy that measures customer loyalty, satisfaction, and enthusiasm for the organization. It's calculated by asking customers just a single survey question on a scale 1 to 10, how likely you are to recommend this product to a friend or colleague. I think those are the kinds of things that should be explored further because CAPS does measure both satisfaction as well as that deeper experience with the encounter. I think ACOs are also cautious about patient-reported outcome measures as they introduce a significant burden and not always are timely. And I know Dana may have some comments on that following me. Also, there's a growing patient fatigue due to the multiplicity of surveys. And almost every provider, think about it, almost every provider in healthcare has an instant experience survey for every patient encounter, whether it be a hospital or physician's office, even sometimes the lab. We know very little about how these results are used by the provider, but we really should. I'm going to offer several suggestions where I think AHRQ could lead the way into a new generation of patient experience data collection. I think first, take a broader look at this area. Namely, what are the best ways to gather and collect patient experiences in healthcare, and not necessarily through just one survey instrument. I think we need to investigate how the technologies of these provider instant surveys, all the social media content about healthcare, and EHRs can replace or complement parts of CAPS. We need to evaluate better ways to time the surveys with the actual patient experience. We need to examine the economies of deployment and how better competition just for the CAPS models could be facilitated. It's a very uneven and somewhat non-competitive market from our point of view, and it's costly. And then examine the possibilities of AI. I mentioned this in the collection of patient experiences, particularly open-ended questions. And lastly, AHRQ could develop a much stronger voice, I think, in standardizing all of those multiplicity of instrument provider surveys so that the patients aren't confused, and maybe we could gather a little more research data from those. How does AHRQ do this? I think I'm suggesting that that the agency allocate funds in next year's budget to launch an independent evaluation contract, independent of the consortium, that would address many of these questions and others, and just offer a list of options for improving the collection of experiences of patients in healthcare. Other federal users of the surveys would help, I'm sure, be glad to help guide the evaluation, including CMS, and maybe even contribute to the funding. And in addition, I think the representative of the private payers and providers would also help guide the contractors' work. So, Bob, that's my recommendation to you. That's my put before the council here, that idea. And I'll turn the mic over to the next presenter.
Thank you, Cliff. So much to unpack there. I want to make sure Danny's slides are up next as we pass the mic to Danny Van Leeuwen.
Hi. I'm here to share some lived experience. I'm known as Health Hats. So the first hat is that I experience care and I fill out surveys. I'm a person with multiple chronic conditions, and I have been care partner to several family members end of life. I am a registered nurse, and I have worked in home care, in the ED, in the ICU, in post-surgical care, and behavioral health. So we hear the results. I wear another hat in that I managed clinicians. And as a nurse manager, and a quality management leader. And finally, now I am a member of the PCORI Board of Governors as a patient caregiver stakeholder, and I've worked with CMS and other measure development on technical expert panels. So I wear a bunch of hats. So oh geez, I'm behind. Okay. So let me tell you some stories from my various hats. So I recently had an MRI. No, I had a C-spine scan with contrast, and I got an ambulatory surgery CAPS survey. I didn't need to answer any questions about anesthesia, but there was no place for me to say it was not applicable. The clinical experience was uneventful, but the billing was confusing, and I never got results through the portal. So I care about, so I didn't have any option to say what mattered to me. You know, what mattered to me was what it cost to me. What mattered to me was access to the procedure as a person with disabilities. What's important to me is how we made the decision to have this procedure and what it was going to do for me. There was, what's important to me was how the facility includes my caregiver, whether the exchange of information pre and post procedure met my preferences
did I want electronic results? I want the portal. I want open notes. Never did it ask any of that stuff. Let's see. So let's put on another hat. So as a clinician manager, the nurses didn't know about the surveys for the most part, and they really didn't care. And if they did, they dissed it until I cared. And when I cared or my boss cared, then everybody wants to get an A on everything. It did not matter what it was about. It did not matter whether anything was being improved. Everybody wanted to get an A from top to bottom on every measure. I tried to, many times in that role, I tried to say, look, why don't we take what we're really crappy at and do better? And no, because it is really hard. It's really hard to go from good to great, but it's not that hard to go from crappy to decent. Okay. We put on another hat. Okay, so I was the director of patient family experience at Boston Children's Hospital. And in that role, I kind of did what Bob did here, is I set up a council of the chiefs, the ambulatory practice chiefs, to try to, how can we improve outcomes and perception and experience? And in their infinite wisdom, that group decided that what was really important was access. And to them, access meant reducing no-shows. Well, okay, that's a challenge. Let's see what we can do to work on that. And I went to our panel of practice directors, so administrative directors, and they knew who was what were the issues with no-shows. And what we knew was that if you took a single parent who had a child with complex condition and other children who took public transportation, they were most of the no-shows. And they never filled out a survey, and they never were going to fill out a survey. Then, when we actually put together a plan for coordination and centralization of appointment making, it was a no-go because it was a feudal system of governance, where each practice manager was didn't want to change. Each chief did not want to change their operations. So the last hat was, so I was VP of quality for a nonprofit that supported 23,000 people with disabilities. I presented survey results to the board of directors. The survey results stunk across the board, really embarrassing. This was an organization that had residents and consumers on every level of decision making, including the board. And I presented this to the board, and there was a man who was a paranoid schizophrenic who went into a 3-minute diatribe to me, being the ignorant person, just listening to this person's diatribe. But after this person finished 3 minutes of I really wasn't listening, which my bad. It turns out that when people were asking him what they thought he was saying, is he was saying people were really upset that when a personal caregiver left employment and a new one came the next day, that there was no announcement of that fact. Well, that is so easy to fix. And in the next quarter, every measure went up. There was no question about it in the survey. Okay, finally, I've got just a little bit of time. Okay, so lessons. I would say the trust and loyalty changing experience include more than experts think. always. It is absolutely always guaranteed. The experts do not know. Second, that experience includes hands-on care, decision-making, transportation, electronic experience, billing more. It includes so much. There's no 100% walking in someone else's shoes. They might not have shoes. The pearls might be under the street light. No, might be in the alley, but you're looking under the street light, you know? So with data and statistics, we're dealing with likelihood. You can increase likelihood by better targeting questions to individual circumstances like Cliff was just talking about, and allowing and managing free text responses. Don't waste questions about stuff the local or national healthcare system is unwilling to change. It is disrespectful of the people who are filling out the surveys, and it contributes to burnout of clinicians and staff. And finally, I think we should be including persons with lived experience in measurement. And when I say including people with lived experience, I'm sorry, in analysis of the data. And when I say people with lived experience, I both mean people who have lived experience and they're learning about the science of experience measurement, and also people who are experts in the science who are born again patients. They've had an experience. Those are very different. Thank you.
Thank you so much, Danny, and your perspective with your many hats. I'm now going to turn it to Miss Cynthia Bland, and just a reminder, your mic, yep, perfect. It's this little icon right here. Yep, maybe move it a little closer, and then you can advance your slides using that clicker. Thank you.
All right, thanks so much. I'm excited to talk about my vision for CAHPS modernization, and my viewpoint is that of a statistician, and as a statistician at a nonprofit, a federal contractor who works on several CAHPS studies. So my comments today are mainly based on a paper that I wrote in 2022 with my co-authors listed here. The full paper is available for free. You can search RTI Press and CAHPS, and it'll show right up. As a foundation, CAHPS data are valuable and important. And this is just really important for patients, for their caregivers, providers, facilities, because respect and quality in our healthcare is essential. And CAHPS is a great way to get at that. And it's even more important as we're moving toward accountability and payment being tied to the CAHPS studies. My paper offers these areas for modernization, but I will have to skip a few today. I'll hit on these topics and really put them under a couple umbrellas. I know this list also might feel kind of bold for some, and I acknowledge that change can be a little bit uncomfortable, but getting even better CAHPS data is essential. So first, as we already heard a little bit from Cliff and from others, some goals that we really have here about modernization are to reduce the cost and increase the speed of these surveys. And the first sort of umbrella we're going to use right now is through survey methods. We think that can get us pretty far. So here are the 5 areas that I'll touch on briefly. We need to address non-response, implement web modes. We need to develop new questions, reduce the questionnaire length, and provide incentives to respondents. We need to maximize response by having providers' offices or facilities convey the importance of the survey. This could be through materials like flyers and posters, but also through that staff buy-in and familiarity. A concern around non-response is that response is different across different groups. And so to address that, we must target the subgroups who are less likely to respond, maybe based on age or language. Let's better reach people by using their preferred mode of contact.
So if somebody responded by phone last time, don't bother sending the mails surveys. Just hit them first with the phone, because that might be the better way to get that completed survey. Just cut to the chase. And we also must have the right languages for people. It is essential to be able to contact harder to reach populations and provide a voice for those people. As we've already heard, folks are experiencing survey fatigue, and across CAPS, we can help each other out by reducing the likelihood of getting a CAPS survey again and again through a particular time frame. Because people have many different ways and times they experience care, they could get multiple CAPS surveys across different programs. And this would take a lot more coordination between and across programs, but it could be worthwhile. So finally, we have to analyze the data for non-response bias. And then if we find bias, we need to correct for that when it's present. Next, web modes. Research shows that web modes can be successful as part of a mixed mode strategy, for sure. As we've said earlier, that is an excellent approach, and the OAS CAPS mode experiment is a great example of that. Additionally, newer research is showing that for some populations, a web-only approach is totally valid. It matters how we're going to contact them. Is it an email? Are we going to send a piece of mail to their home with a link or a QR code? Will we text them a link? We need to think about how recently that patient record was updated to see how we would best be able to contact them. And of course, we need to think about how we're communicating with people. And that's especially around the concerns around phishing and spam. We've been really good about telling, at least my mom, not to click on those links, but we're going to have to change that message if we're changing some of our survey approaches. When we talk to survey vendors, they say that web, and specifically web only, is the mode that people want to respond by these days. Next is to develop new survey questions. We need questions that are relevant to the patient experiences and questions that have room to grow. And so these are questions where facilities can be differentiated from each other and where we can go from crappy to decent. And those may be questions around technology, like telehealth or portal usage, but it could also be around more robust questions for gender, racial identity, and disability status. We need the demographic information that respects individuals around these topics. And we must also ask if people are experiencing different care from providers based on their personal identity. There are emerging topics around non-medical needs too that could be addressed in this Develop New Questions framework as well. Now, I know I said we just need new questions, but also the point, as Cliff said before, is that we need to reduce the questionnaire length. These are not in contradiction, because some questions might be ready for retirement. Stakeholders do express concern about the questionnaire length, and we know that shorter surveys increase survey response rates, and there's a lot of ways to investigate this. The paper goes into more details about technical expert panels, about focus groups, cognitive interviewing, and other options. Finally, we need to consider incentives. I know this is a tough one because currently CMS does not allow incentives for survey vendors or health providers to give to patients, but incentives are effective. These could be monetary or non-monetary tokens like a bookmark, magnet, sticker. Monetary ones are best, but even something like a magnet or a sticker may increase response rates and participation. The timing matters. Is this sent in the mail when you're getting your invitation? Is this a postpaid or prepaid kind of a thing? And yes, it would be an additional cost, but we think that the cost would be worth it and it would reduce the overall fielding costs. I would love to see some experiments here, and that would really help us move the needle on response rates. My personal favorite is moving on to our sampling perspectives, again, for reducing cost and increasing speed. I'll talk mainly about two strategies. The first is a Bayesian approach, and this focuses on the score. So this is using a facility's prior score as a prediction for this year.
And that could allow a smaller sample. So especially if the score is on an extreme, so very high or very low, that could give us an opportunity to have a smaller sample size as opposed to a score being in the middle, more like a coin flip. That's when we would need to have that larger sample size to get a good estimate. The second approach is a variance-based method, and that's when we'd look at within facility variation to help allocate our sample. So you can think of variation as a measure of patient agreement. So briefly, if we have a lot of variation, or we have a lot of disagreement amongst the patients at a facility, then we would need more completed interviews to get a good score. But if we have less variation, more agreement, we could probably get away with a smaller sample size. And so this all goes toward cost. And the paper also talks more about adaptive design. We can get into that in the Q&A if you'd like. But since everybody else was also talking magic wands earlier, I'll share with you a few last big ideas. Let's normalize the idea that responding to CAHPS surveys is a good thing. By talking about those surveys and the survey process and the value of CAHPS during someone's Welcome to Medicare visit, we can explain that we care about your care and that we use these results to help people. And while I'm wishing big, we've already talked a little bit about survey fatigue. And I'd love to talk more with Cliff later about this one, but we have a lot of facilities who send out their non-official CAHPS sample every month or every period. And this wears on people. And it also reduces the likelihood that they will respond to the official CAHPS study when it comes to them. I mean, if I could really have my way, we would just never get any more surveys for hamburgers or sneakers or anything like that. But, you know, a statistician can dream. But I think that's our time. So here's my contact info, and I look forward to the rest of the conversation.
Thank you so much, Cynthia, for sharing your perspective. And I'm so thrilled that statisticians exist in the world because people like me need people like you. I'd now like to turn the floor to our fourth panelist, Dr. Dana Gelb-Safran. The floor is yours.
Great. Thank you so much. And I'm really pleased to be able to be with you. Apologies for not being there with you in Baltimore. I'll be there with you on Sunday. So looking forward to being there then. So I'll share with you some perspectives from having sat on different sides of the table relative to CAHPS. In the earliest days of my career, I was a measure developer and in fact, a developer of measures of patient care experience before there was CAHPS. And then once there was CAHPS as part of the then Harvard, now Harvard-Yale CAHPS team. And in that period of time, one of the things that really was important to our findings in our work was that the measures of relationality in care, which were central to the tools that I had developed in 1990 and between 1990 and 2000, those measures proved to be the biggest and most important and most consistent predictors of outcomes of care, both business outcomes and health outcomes. In particular, from the instruments that I developed, the first of which was called the Primary Care Assessment Survey, the second of which was called the Ambulatory Care Experience Survey, and that latter one really became an important basis for our work on CG CAHPS. Those two tools both had a great depth of measurement related to the quality of clinical relationships. They evaluated how well patients trusted the clinician that they were answering the questionnaire about. They evaluated whether they viewed their care as being whole person oriented. They evaluated communication quality, interpersonal treatment, continuity of care. And in study after study, both our own studies and others, what we found were that the measures having to do with relationality, and in particular, the measures of patient trust and whole person orientation to care, predicted outcomes that matter. The malpractice risk, the loyalty to a practice, other business outcomes, as well as clinical outcomes, adherence to clinical advice, improved symptoms, and health status. And so as we think about the future of patient experience measurement, I wanted to bring that back to the front of our attention, so that we really don't shy away from the importance of relationality in healthcare as a driver of all the things we're trying to produce, both on the health side and on the business side. I'll turn next to a role that I played while still in academia and developing measures, but in this case as an implementer of measures working to help provider organizations with improvement. So it was about 2002, the Institute of Medicine had declared that patient experience was, or patient-centered care was one of the 6 pillars of high-performing health system. And suddenly, as you all know, every health system in the country was including patient-centered in its mission statement, even if it didn't quite know what that meant or how to achieve it. And I had the incredible good fortune to work with some systems that were working to improve patient experience. And one of the things that we learned there was the importance of ongoing, consistent measurement for clinicians. And in fact, what we found was that the clinicians whose own performance was being measured, along with that of the practice sites that they belonged to and the health system that all those sites and clinicians were part of, the ongoing measurement and quarterly updates about performance with adequate sample size quarter by quarter to have stable, reliable information in each quarter did more than any of us who are methodologically trained could have done to convince clinicians that there was something real being measured here. In the beginning, you can imagine that most clinicians felt there was no way that a sample of 45 or so patients could be a way to capture their performance. But as they saw that quarter after quarter, their performance looked the same, even with different patient samples every quarter, they came to believe it. And they also came to really lean in to the organization's efforts to work on performance improvement. The next opportunity I had was to sit on the side of the table that is the payer side, and to be one of the architects of a value-based payment model called the Alternative Quality Contract at Blue Cross Massachusetts, starting in 2007, that used patient experience as one of the 3 domains of measurement that were central to the AQC performance improvement incentives. So there was accountability for total cost of care, and there was accountability for quality, including process measures, outcome measures, and patient experience measures. And I was in a conversation on a webinar yesterday where it seemed that folks were surprised to learn that there was absolutely no clinician or health system pushback that we chose to include patient experience as on equal footing. And I really attribute that to the great work that AHRQ and the CAPS teams have done over so many years to gain the acceptance of this area of measurement. And so that took its place. And I would argue that as we move increasingly toward accountability for total cost of care, that while quality overall is a critical backstop to any impulse or concerns about impulses that might exist for stinting on care, given a global budget, patient experience is probably the best of the domains of measurement to be that backstop, because it is virtually impossible to game a patient experience measure. And so then finally, I'll go to my current role where I lead the National Quality Forum. And as part of that, lead an initiative called Aligned Innovation, where we have a multi-stakeholder coalition of public and private sector payers, purchasers, and providers who have agreed to align on what are the highest priority measures that they need that they don't have today. And what I can tell you is that at our earliest meeting in October of 2022, when we began this work, the highest priority area that coalition wanted to work on were patient experience measures. And that really struck me. It was very confronting, to be honest, as a former member of the CAPS team, to be talking to stakeholders who said, we are ready to do something else. CAPS is no longer serving our needs. And so fortunately, I was able to work with this coalition and help influence their decision to try to, rather than compete with CAPS, inform CAPS, influence CAPS, and there have been several, I hope, fruitful meetings along those lines. But in the last couple of minutes that I have, I'll just share, I think Cynthia really hit on the key topics of the kind of innovations that we need to see. She talked about new modes, and, absolutely that is one of the areas that I hear over and over from both the Aligned Innovation Coalition and from NQF stakeholders overall. Everyone is clamoring for patient experience measurement, and that's fantastic, but they want it to be modernized. They want us to be using modern methods of administration, as Cynthia shared. By using web-based or even phone-based methods, we can leverage dynamic design and ask patients the questions that are relevant to the responses they've given to us on their previous responses. That kind of dynamic design is so critical to where we need to go. We also need to have new questions. Cynthia talked about that. What I would share from my experience in the years of doing measure development in this area was we have to have the courage to ask about things that might have gone badly. I can remember clearly when we were developing CG CAPS, there was a question we wanted to ask about how often in your interactions with this clinician have you been interrupted when you're trying to share information. Ultimately, there were stakeholders who did not want to see questions that were posed about things that are negative. But we know that one of the challenges we have with patient experience measurement is things look topped out. Communication, we all know from our own personal experiences and our family experiences, are not as good as the CAPS scores make them look. And we can get to better, more robust information, better differentiation across care settings and clinicians by asking about some of the negatives, about were you ever treated disrespectfully? Were you interrupted? Did you feel rushed? We can't shy away from asking new questions and asking about some of those negative questions and really learning from patients as we design the questions when they've had a standout experience. What is it about that experience that makes the care stand out as patient-centered? And let's ask about those things. Cynthia also talked about length, about response rates. One of the other areas I'll emphasize before I share one of my magic wand moments and then close is the use of AI, which I've heard others point to, really has to be explored for CAPS, including because it can open up the possibility of including patients who speak languages that we don't have translations for, couldn't have translations for. But by using AI, we can enable use of narrative, extracting from that narrative the quality meaning of what's being said, and it can be done in any language. So I'll close with what my magic wand list has been or item has been. And this goes back to a concept that I had probably in the year 2000 or 2001 or two. And that was, we could so easily have a national directory of clinician experiences for every clinician in the country, knowing that all we need to get stable, reliable information about patients' experience with a clinician is 45 responses. If patients felt, and again, this will build a little bit on Cynthia's notion of the Medicare onboarding visit. My notion had been if everyone knew and understood that they would get just one survey per year, and that by answering that survey, they'd be helping to build and maintain a national directory of patient experiences with clinicians, I believe that we could easily create a directory that had 45 current ongoingly refreshed responses from patients, and that would really be able to inform patient choice, and also inform ongoing performance improvement. So I'm looking forward to our dialogue. I thank you for these few minutes to share some of those thoughts and experiences.
Thank you so much, Dr. Safran. There are so many beautiful threads throughout the 4 presentations to begin to sort of weave together and extend. And I can see that there's already many hands that are up. And so what I'd like to do is I'd like to give each of our panelists 90 seconds to respond to sort of what they've heard, and then we will open up to the NAC. And so, Cynthia, I see you have your microphone on. I invite you to go first.
Thanks. I'm going to address this to Cliff. I'm curious, you said that the sort of, I will call them extraneous, but I know they're not, the facility-based independent non-official CAP surveys, that people don't really know what to do with them, aren't doing much with them. Does that mean there wouldn't be a lot of resistance to, say, get rid of them?
Well, I think they rely on them for the more, yeah, I don't use the right word here, mundane administrative evaluations. Were they happy? Did they have to wait a long time? And what was the wait time? They can't gather that always. Although EHRs now are better at it. You check in when you arrive, and the HR should know when you're being seen. But I don't think they'll abandon them. It's like a blanket, a comfort blanket maybe, but I think they could probably be better standardized. And I'm not so sure that for that element, if we had some common questions that they agreed to ask, we might be able to almost, not need a portion of the caps. But these are things that have to be really experimented with and evaluated. And I think AHRQ's got to put some money into doing that.
Mm-hmm. Thank you so much, Cliff. I'm going to turn the mic to Danny to sort of share your reflections, and then you haven't had a chance to make a comment about a magic wand or magic hat. If you had a magical thing, what would you do? So first your reflections, and then what would be your magic wand moment?
I think that what are my reflections? I think about the single parent who has a child with complex conditions and other children, and I'm thinking about there being a community health worker that's a part of the practice and maybe walks them over to a kiosk and walks them through a survey, and they capture that survey and also provide that moment of education about how to use what we're saying. Most people are going to online surveys, but most people means 51% or more, which means there's plenty of people that isn't. So I'll stop there.
Thank you. And what's your magic wand moment or magic wand action you would take?
I would have, as I said, I would have people with lived experience at every step of the process, from the development of the survey through dissemination, through analysis, and then dissemination of results.
Wonderful. Thank you so much. We have hands that are continuing to accumulate. And so we're going to start with the NAT comments. And if you're directing it to a particular panelist, please make sure you mention that. And if your comment is something in general, you're just open question, please make that designation. We're going to start with Peter Angood, who's joining us virtually.
Hi, everybody. Peter Angood, and I'm kind of having one of those feeling like I'm in the field of giants moments with On and Dana and the others. So thank you for some wonderful presentations. Comments primarily here, and that is as a consumer, I think we're heavily overburdened with survey work, not just in this industry, but all industries. And so I think we have to recognize that the patient population and the families are probably feeling that overburdened. So as we do a redesign, how do we make it quick, efficient, relevant, all those types of things? I recently had my car repaired, got the usual surveys, ranked it in 7s and 8s because of the experience. I had a good relationship with the service manager. He didn't like my score, so he immediately got on the phone to me. And why? Why? Well, he was concerned because his other workers were going to get a $500 less on their compensation because I had bumped their net promoter score down. So there's competing forces out there on why people do or do not complete these things. I represent an organization of physician leadership, and all physicians are leaders at some level. And this concept of measurement comes up regularly. And I think it's fair to say the physician workforce is still very sensitive to measurement. And yes, they embrace patient-focused measurement, but they're still sensitive to the measurement inside their own work and what's relevant, what's not relevant. And so I think we have to, not just for physicians, but other in the clinical workforce, keep trying to get that interrelatability that Dana was talking about a little bit earlier. And then Dana, I hate to mention this one, but I am very privileged to be the chair of an NQF Professional Society Advisory Committee or Council that's just been activated for the first time. We're only a few months into this work. And when we were trying to talk about what was relevant for professional societies, right to measurement burden, and how do we kind of make it relevant, meaningful, interrelated, less of a burden, all those kinds of things. And so we have to think across the spectrum, where does the consumer stuff come in here as well? I know there's a lot of other hands, so thank you for the opportunity. Great presentations.
Thank you, Peter, for your comments. Dana, would you like to react to that? And then I'll invite the other panelists if they have any reactions.
Oh, thank you. You know, one reaction, Peter, related to your car service experience is how troubling that the service knew who was the respondent, right? That there wasn't anonymity there is troubling. So we're lucky in our field not to have that particular challenge. But on your point about, burden, this is one of the great blessings of the opportunity that NQF has now to really go after the issues that I've described as upstream and downstream from our nation's portfolio of measures, right? What we get to work on now are those challenges that you spoke to, Peter, and that we know are the ones that are talked about every day in our field. We have too many measures. We aren't measuring the right things. Measurement costs too much and takes too long to develop new measures. We have competing measures, different payers using different measures, and the burden of the data collection, the burden of the data reporting. Those are our agenda now, and Aligned Innovation, which I spoke about, really is committed to development of measures that really represent what are the right things, and to do it in ways that are removing burden. So we're really privileged to have that opportunity, and we really understand that right now, I would say our field, quality measurement, not just patient experience measurement, has a black eye. Mm-hmm. And we have work to do, but I feel very excited about the opportunity that we have and that I get to lead at NQF to solve some of those problems, because I do think measurement is the lever that best positions us to get the delivery system that we all want. Thanks.
Thank you.
Thank you. Any other panelists want to respond? And then we've got tons of other comments in the queue. Okay, we are going to go to Jaji, Sunil, and then Al, and then I know we have others. Jaji, you're up.
Okay, just one comment on the data collection part, and afterwards, potential new methods we needed to analyze data. So today with today's technology, for the CAF survey, for instance, we can implement this based on a large language model with good developer in our school, maybe a few hours, few days at most. That can make it a conversational survey tool with any language. The models can handle almost everything. It can translate back and forth. And it can capture even more information than you need. Basically, based on the structured data, structured question you have, ask question interactively and incrementally, and the data can be collected automatically with real conversation in speech. The data can be collected, and so now the big question is, when you have the data, how do you analyze the data in the way that you want to, especially for comparison?
A very important question. I would love to hear, Cynthia, perhaps your initial thoughts and then other panelists.
Sure. I think one of the key things there is looking at mode effects and understanding, how that would be any different for, people who want to have that interactive experience with an English option, if that's their home language, or with the other options that are being produced, and having that interactive thing. It might be a great new thing. I know that historically there were options like the push a button aspect on the phone. Some people didn't like that. And I know this is a far cry from that. But I think some experimentation there would be great. And then being able to analyze it as is, I think is fine. So I think there's options there.
Just comment here, the language can be detected automatically. So that's not an issue.
Okay.
So Cliff, if this new approach sort of comes to pass, from your vantage point as a sort of leader of, sort of ACO organizations, what do you think about sort of the integration of such an approach? Do you think that would be well received?
Absolutely. I mean, anything to one, relieve the burden and to get better data. I mean, ACOs want their performance with their patients to be measured accurately. That's probably one of the most proudest things that our organizations want to be able to publicly talk about. And but they also are, one of the characteristics of those organizations are they are very frugal. They watch their pennies. That's the only way, with the tight benchmarking and all the other regulations, for them to find a savings. And they can transform the care, which is hard to do, but they also look at their underlying structural costs. So cost of surveys are important. Any way to bring new technology to it, whether it's AI or just web-based surveys, I think it'd be widely welcomed, just without a doubt.
Thank you. Sunil, the floor is yours.
Thank you. I've really enjoyed this discussion of innovative ideas to improve measurement of consumer experience. There's one which the panelists didn't explicitly mention, but I'd love their comments on, which is around continuing to measure and perhaps even expanding the measurement of continuity of care and the patient's experience through that. It's clearly important in AHRQ's priority list. And I mention it for two reasons. One is, as patients are moving from one physician or practice setting to another, they have a unique perspective on how well that care is handed off and coordinated, which could have an impact on efficiency as well as diagnostic safety and treatment. The other part is, we know, for example, when patients are transferred from one hospital to another, they're much more likely to experience delays in care, a higher rate of adverse events. And we, to my knowledge, don't have a way of capturing patients' perceptions of that handover from one acute setting to another. I'd recommend that these be part of our measurement of patient experience, and would love the panelists' thoughts on this.
Kenny, I was wondering if you could share your perspective as a patient experiencing care and then also as a nursing leader.
Well, I think we have some competing incentives here, because in my experience being on different TEPS like I'm on a cost and efficiency tap first with NQF and now with Patel. And it's all about not getting dinged, and I'm not responsible. And so the problem with while I totally agree with you as a patient that the continuity of care is really important to my experience, hugely, because I see 6 different specialists in 3 different systems. They all use Epic, and none of the Epics talk to each other. But still, well, I just, imagine being in the meeting when we're reviewing evaluating the measures, and it's going to be, well, I can't be responsible because that happened over there. And so I think there's something needs to happen with that incentive. I just don't know that this idea of dinging people for their outcomes is like helpful, even though it's a blunt instrument we use.
Your comments have generated a cascade. I'm going to go to Dana, then Cliff.
Oh, thank you. Yeah, I can't underscore enough how much I agree with the importance of continuity being part of what we're evaluating. I spoke during my remarks about my experiences working in a health system that was looking to improve patient experience. And what I didn't share there, but I will here, is that part of what that system had in place that was undercutting its patient experience was what their chief medical officer referred to as mob care, even though they internally called it team care. And the problem was that they weren't using communication with patient to help the patient understand that there was a coherence to the team. So the patient just experienced discontinuity. And we were in our tool measuring 2 different types of continuity. We were measuring visit to visit continuity. That is, how often when you're being seen, are you being seen by the clinician that you consider your regular personal clinician? And longitudinal continuity. How long has this person been your clinician? And what we began to see was that even without increasing visit continuity, by creating what we call visible teams, getting again away from that idea of a mob experience and more to a coherent team, the nurse practitioner or PA who is seeing you would explain their relationship to the person you think of as your regular personal doctor and how they will make sure that person knows about your care today and what's going on with you. Just by creating that visible experience of continuity, those relationship scores, trust, whole person orientation went up. And as I said before, those were the measures that predicted the outcomes that we all want. So, I think one of the things every patient will point to when asked about what's wrong with the system of healthcare and what goes wrong is a sense of fragmentation, and that they repeat their story over again, and no one seems to know what happened, even if it was 5 minutes before with somebody in the same office suite. And so I think this issue of continuity is very important, but how we create it doesn't necessarily have to mean you're seeing the exact same person every time you're being seen. It's the way teams are relating to each other and revealing that to patients that I think matters so much.
Thank you, Dana. Cliff.
Just very briefly, I'll put in my pitch here for better measures, more measures, and required measures for performance around continuity of care. If there's one thing that you would call secret sauce in an ACO, it is how do they accomplish that smooth continuity between providers and provider settings. And we just don't have enough good measures of it. There is a measure working its way through the process that CMS and Patel is now managing, addressing that. It's just one measure, but I endorse it strongly. It's probably the weakest area, and maybe the most important area to learn more about as we try to provide whole person care for everybody.
Thank you, Cliff. Al, you're up next.
Oh, First, thank you for this presentation. I have a bunch of notes here, a lot of shaking my head in agreement with your wish list and what have you. So I apologize in advance if these comments sound screamed in some way. But first, I do agree. I think there's a concern with survey relevance. And I have a similar example to you, Danny, where I went to see an ENT and immediately afterwards, he was like, well, I want to go through these survey questions with you because it's going to impact my Medicare payment otherwise. And not knowing the intel that I know now when we were going through that, I didn't think anything of it, but I'm sure he did that numerous times on a daily basis. So when you start tying things to payment, the relevance of it takes a different form, which is very concerning. Looking at it from a pharmacist standpoint, I know if in some of the surveys in health systems, many of the questions that are tied to the provider are pharmacy related questions that the provider may not be providing that service. So, Cynthia, you mentioned, in your wish list of looking at new questions or new format for questions and developing these new questions. And I think that's very important as we look at this moving forward. I think the mention of AI in the translation, I think AI can be used outside of that. I think there are many ways that we can tie in AI to make these surveys, if we continue down this path with the survey as that proper format, more relevant, more efficient, and just easier to use as we go in that place. And I completely agree with the continuity of care. I think that these surveys, even with pharmacy, and before I served in the current role, that current capacity, I was the quality VP for a large chain pharmacy, and we used these surveys. The challenge with the surveys, though, were we got the patients at their worst part. These patients are coming in sick. They are aggravated. The only thing they want to do is they want to go home. And so the survey responses that we got were majority of them were negative, and you don't get that the box experience where pharmacists is going above and beyond what they normally do to take care of that, because those patients are incentivized, as Cynthia said with her wish list, are incentivized to fill out the survey. You're getting the surveys from those that are just aggravated patients, and it's very challenging. That's why when we look at the survey relevance, we need to take a hard look at all of these aspects when we look at those considerations.
Thanks, Al. Cynthia, please respond.
Sure, you're right. We can use AI in many other ways. One of the best uses of it that we've seen in other surveys is for open-ended questions. As Danny was saying, he wants more places where he can have that. It can do a great job of synthesizing information like you may have used for note-taking or something in a large language model, but it's also very good for understanding sentiment. Not just positive, negative, but also just the forcefulness of that or the strength of that sentiment. And those could be good measures. As we've talked about, whether it's your car repair or any other aspect of surveys, we do really want to make sure that we're dealing with privacy in the correct way here. And so I urge us to think about how we're using AI, not only from the privacy of those external or internal models, however those are being built, but also that clinicians are not receiving enough information that they can identify patients, that we're maybe thinking about this in terms of sentiment or something that's protective of responses.
Thank you. Cindy, the floor is yours.
Hi, thank you so much for this. As somebody working in, the patient centered advocacy space, this is very, very important, and I'm very interested. It's been a very interesting presentation. That's going to make it sound really weird what I'm about to say, which is that I think it's really important that in contexts like these, we investigate our assumptions about the value of consumerism in healthcare. Because there is an assumption, especially if we start looking at net promoter, we're not buying hamburgers or changing oil or any of that, right? I think the points that were made earlier about the value of the relational part of the interaction is supremely important. And it also assumes that people have a choice. in these spaces, I have to say over and over again, people have very, very limited choice. Even people with really good health plans have limited choice. Where you live, you know, you can, even in Washington, D.C., in the metro area, there are people who have excellent health plans and cannot find a primary care doctor on the plan that is taking patients, right? So all this idea that we're going to solve this through like better consumerism is blaming the victim, right? So that's the first thing that I wanted to say, that it's very important to measure patient experience for the reasons that Dana was talking about, because when you are measuring the right things, you're measuring the relationship and trust, and then you actually get to outcomes that really make a difference. The reason why you want to make sure that you're asking the negative questions is because not just because it's easier to go from crappy care to decent care, but when you go from crappy care to decent care, you're also saving a life, saving a family, saving a limb, saving people from years of disability, from, mental health crises. That is the goal. I appreciate that in this country, there has to be a business imperative as well. So I was really excited to hear, Dana, what you were saying about it also solves for that. Because you don't often see that in healthcare. But I do think that it's extremely important that we are talking about the importance of asking patients how things went. Not just because you want to find a way to not get dinged or make more money. I do have one technical question for the statistician. I thought it was very interesting how you were talking about that there's ways to have a smaller sample size. And my question with that is, how does that square with challenges about sample size for if you want to look at racial and ethnic and other inequities, right? Because I don't think 45 is going to get you to that.
Yes, that's correct. So that would not allow, it would not typically allow for subgroup analysis. So if you're looking for minority responses, or you're looking for particular people who are experiencing a certain kind of healthcare challenge, that would not be the thing. So I'm thinking about the experience that I have for, say, home health caps or OH caps, thinking about it from just, an overall facility score, that you could be reducing things down, getting those smaller sample sizes. But yes, you'd be missing out. There's value in those larger sample sizes, but depends on if people are willing to pay for it. Yeah.
Carrie, you're going to have the floor next, but I want to see if any of the other panelists want to respond to anything else that Cincy said.
Yeah, could I? So to your point, in employer-sponsored healthcare, about half of people in employer-sponsored healthcare are only offered a choice of one health plan. And if you only have one health plan as a choice, the CAP surveys and the consumer experience are kind of irrelevant. So this is one of the big problems with, measuring this. The other issue is, for quality improvement, the people you really want to hear from are the ones that are using the system the most and have the biggest problems with it. So, when you say that the survey is biased because, we're talking to people at their worst, that's kind of what we really want to know. We want to know when things are really bad. We want to know about it so we can fix it. If you go out and talk to people, most of the time they will tell you that their health plan is fine, their doctor's fine, but they're not really using services. And what I have found is that when people start using the health plan, that's when they begin to become less satisfied. And that's the information we really need. Doing a broad survey and getting reports back that things are fine is really not helpful.
Thank you. Carrie, the floor is yours.
Thank you so much. This has obviously been extremely interesting based on the engagement. So I'm interested to hear from the panelists the status of nursing home caps. And the background I'll give is just, as a geriatrician, at least once a week, somebody will call me and say, I'm moving my mom or
to an assisted living or a nursing home, and I don't understand the star ratings. And, it has a 5, but everybody tells me it's terrible. And so I've always wondered if we had a way to do this, maybe in the conversational mode, if that could be sort of this constant feedback so that CMS can go to the facilities that are having more trouble and spend their efforts on those and not spend as much time on the ones where you've got great caregiver feedback and patient feedback.
So unfortunately, I can't speak to that survey particularly, but I do feel like one of the places for improvement really is in how the public uses the star ratings, or just even that Care Compare is out there. I feel like I drive my family and friends crazy by suggesting that. I drive all the traffic to that website, I feel like. Hopefully you all do as well. But I think that using some kind of, video, or even really just having focus groups with general members of the public to be able to understand more about what they're gleaning from that or missing from that resource would be really valuable. Statisticians, we're not known for our communication skills, and just broadly, we need to understand how to make that more accessible. So I would love to see more outreach with patients and others about what's really happening there.
Thank you. We have Liz and then we have Michael. Liz, you're up next.
Hi, can you hear me okay, Kamal, this time?
Yes.
Okay, great. This was the most interesting panel on these kinds of measures that I've heard in a long time. And I've been a big proponent of patient measurement, dating back to the picker days, like from picker days to proms, So this is really exciting about the kinds of things we can do in the future, addressing new areas of patient experience, more tailored, et cetera. I'm just going to jump back, though, to Peter's comment about another P, the providers. And I'm wondering if we can think collectively about how to use these measures in a way. I mean, Cliff, you do this with all the ACOs, how we can use these measures in such a way is to inspire improvement and not to make them feel like, oh gosh, it's just another report. I'll never be able to improve that because they don't have the resources. They send me this information, but I don't have any way to get on time for my visits. And we're quite concerned appropriately about patient confidentiality. And yet I hear complaints from my physician colleagues all across the country that are now having reports put on their websites at an individual physician level. So how can we develop a healthy dialogue that, Dana, you mentioned a black eye. Maybe it's a black eye, but how can we get people more excited about this? Because I don't know anybody in healthcare who doesn't want to do his or her best. And I think it's the lack of prioritization, resources, and time to give people a chance to see the scores, support improvement, and improve the scores. It is probably what frustrates people the most. So how can we develop a narrative and a process that makes us all feel like we're rowing together on this?
Go ahead, Cliff.
First of all, our members take these surveys very seriously, and many have their own to supplement the actual CAP survey, and the problem, again, this is using a survey to change behavior is a longer term solution. The not being able to actually know who the patient is responding and being able to understand better what the problem is a barrier. And Dana, I think I hear you about the confidentiality issue, but I also have to tell you that if we knew the patient, we could better understand it. It's you have one answer, yes or no, or one 2 on a 4 scale across all of our patients doesn't really help us use these in any instant way to fix problems. So I like that. I'd like to debate that question more about whether there's parts of a survey that are available to the providers. Patients are not bashful about this, and so anyway, and I guess secondly, I feel like the movement to more usable patient experience data is just in its infancy, actually. The web and AI is going to transform the uses and the power of that. And so as a patient, many times now I'm in the age cohort where I use a lot of healthcare and I have to find healthcare in my family. And I do the best I can with what's out there, but it's largely insufficient to really find the right provider circumstance. And there's some pretty important data that's missing. If you're going to have surgery, you want to know how many procedures that surgeon has done in a year. It matters. We don't have that data. We're not going to get that necessarily from surveys. But anyway, that's part of the broader picture of patient experience and the data they need.
Thanks, Cliff. Dana, I'm going to turn the mic to you, and then I'm going to actually ask Danny to react after this. Go ahead, Dana.
Sure, thanks. So I'll say two things. One, Cliff, in response to your question and desire for a debate on confidentiality, you know, one of the things I know from the years that I was working on developing these surveys is patients feel enormously vulnerable answering questions and fearing that what they say might affect the care that they're given if they say anything negative. So I do think we have to be really, really careful with that if we want to get, you know, reliable information. And Liz, I loved your points, and I think one of the things I'll just share, again, back from my experience working in a health system to support their efforts on improvement, was we worked a full year on the kinds of changes that could be made by the system itself to improve patient experience with their individual clinician and that clinician's practice. So even though the questions were about your experience with that clinician, we saw scores improving based on things that the system was doing. And so I think that feels like one aspect of the answer to your question is it doesn't have to be on every individual clinician for what are they doing about the results that are specifically about patients' experience with them, but how as a site, as a practice, as a health system, what are the things that we can do that overall improve the experience that our patients have and support our physicians and other clinicians in delivering care that patients will experience as truly patient-centered.
Thank you, Dana. Danny, what are your comments? Oh, sorry, Cliff, go ahead.
One retort back, Dana. I wasn't proposing all data be publicly shared with the provider. I think having an option at the end of the survey, are you willing to discuss this with your provider, would and really embellish a much better learning experience for the provider than just the yes no answers. So it's just the option should be available. Sorry, Danny.
So I have a couple thoughts about it that are different. Really, I'm feeling schizophrenic about it. On the one hand, I feel like I want to be able to express my concerns about my experience. And I want somebody to hear me, and I want somebody to do something about it. On the other hand, once we develop an industry around measurement, then we not only want to dump everything into that process and have it serve all sorts of masters. And I think about what Aaron Carroll was saying about, like, what are we doing it for? Do we want to manage cost? Do we want to weed out bad eggs? Do we want to improve experience? Like, what are we doing it for? And decide, and then do a good job on that, and not expect it to do all this other stuff. Because even though with my patient hat, well, whatever, one of the hats, is I want somebody to do something as a quality improvement guy. That survey is like of no use. And when I've ever been, I worked for a rural health system and we stood up a new breast care service, and we did our first round of surveys, and oh my goodness, something I don't remember what was really bad. But then we had to say, okay, we need to study this and we need to work on it. And we need to have a regular pulse check, that we do every month. We can't wait for 5 years or 3 years, or I'm exaggerating, but whatever. Anyway.
Thank you, Danny. I'm going to turn the floor to Michael in a moment. And, Danny, as you were talking about the sense of systemness, right, rather than tagging to individuals as a chief quality officer, that makes my heart sing a little bit. And we've sort of asked that each department, each area sort of adds it into the work that they're doing and recognize that it's sort of all of us, right? And it can't always be tagged to one person. Michael.
Daniel, are you going to put on an OPA hat for us? That's a grandfather. It's a great panel. So I was bothered by one of the same concerns that Mario had, and that's about the saliency of the population being surveyed. You have all the time the health plans go, everybody loves us, but are the people who really had to use you, do they love you? And, CAPS was developed as the consumer for health plans. HP was for health plans. And then when managed competition didn't happen, they were lucky enough to make healthcare one word, put in the word providers, and we don't have to change our acronym. But it turned out that managed competition, you get the one plan that does everything, who did not run the world. And today's health plans with, PPOs and all the other acronyms are not what managed competition had in mind. And I sort of wonder about the saliency and Cliff on the ACOs. I mean, I researched them. We looked at patient-centered people for the ACOs, the leaders. I'm familiar with all the incentives. Nobody knows that they're in an ACO, for God's sake. Why are we surveying and they barely know? I remember one HMO person told me that the best name for an HMO after they surveyed consumers was "don't know." And that was in Minneapolis, right? And so, I'm in an ACO, and I feel like asking my doctor, do you actually see more quickly because somebody tells you I'm in an ACO, and all these things so I just kind of wonder, and lastly, this doesn't really have to do with CAPS, but it does have to do with context again, which is salient populations. Is when you have a patient-reported outcome survey, I got one some researchers were doing that had to do with hernia surgery I was having, and they ask you about your functioning. That's great. They didn't ask me what I did for a living. Was I a construction worker, or was I a guy who sat in front of a computer typing, right? And so the researchers, again, need to have some real world context, both for saliency and sort of the context of who is filling out the CAP survey. Just one last comment in terms of the clinicians not believing it. I remember sitting with people from New York, and they said, we get lower scores because we have New Yorkers. They're dissatisfied. And then sitting with some people in Iowa said, we get lower scores because we have farmers, and they're more likely to be hard judges and dissatisfied. So just like every clinician will tell you, my patients are sicker, also my patients are more likely to complain. So what do we do to have saliency, and what do we do to have context?
Thank you, Michael. Would any of the panelists like to react to that?
I have to say, I react to the HMO world. We are, ACOs are not HMOs. We once started, I worked in the HMO business in the very early days. The whole concept now has been morphed into something that is not an ACO, and the access that we try to provide and not limit that access under traditional Medicare is what distinguishes us from MA, and I think the quality outcomes that we do in aggregate are better. There are definitely a massive differences in both cost savings and quality scores across the industry. But there are a high percentage of very high performing ACOs.
All right. With that said, how did this time go by so quickly? Before we move to close, I'd like to give the mic to the panelists last time. Rapid fire, one thought. And remember, we are at an AHRQ NAC meeting, right? One thought that you'd like, to be included in the minutes and for us to take away. I'm going to start with Cynthia, then Danny, Dana, then Cliff.
I think survey fatigue is going to be the one thought that I'm going to leave us with, that we can do better. We should do better. It's hard to coordinate with other contractors and across organizations, but I think it's worthwhile for the quality of the data that we'll end up with, and maybe the less dissatisfaction of people with having to take surveys.
Thank you. Danny, rapid fire.
I would say, however you now incorporate and engage patients and caregivers in this process, do one more thing.
Dana.
I love that, Danny. I would say thank you to AHRQ and to the CAPS teams, because 20 years ago, we didn't dream that there would ever be chief patient experience officers and that C-suite executives would pore over data and really care about the patient experience. We have that in place now, but we have to all understand we really haven't created the patient experience that any of us is committed to. So now's the time. Let's make some really important improvements in the questions we ask and the methods we're using and the ways that we're using them, so that we can really get where we've been trying to go for 20 years.
Thank you. Cliff.
I guess first, it's great homecoming for me, and I appreciate all the panelists and the staff for engaging on this issue. I think that I didn't have a chance to sort of wave my wand, and I want to do that by just saying that many years back, when I was the administrator of AHRQ or ACPR at the time, wrote a vision paper for what healthcare IT should be in the 2020s. And I have to say that we are missing some really important ingredients that were part of that paper almost 40 years ago. And one of those is that our systems don't talk to each other. And it's a tragedy that they don't talk to each other. And I'm talking not just about electronic health record systems. I'm talking about even integrating the patient experience into a single source of information for patients to be able to access their healthcare, monitor their healthcare, and seek out the best care they can. And we're not yet there, but I'm sure everybody is thinking about that these days. And I just want to also say thanks to the staff who have carried this project for almost 30 years. So, thank you.
Amazing. Thank you so much. Can you join me in giving our panelists some applause? So I wanted to thank all of our presenters today for such a meaningful, sort of thought-provoking discussion. I'd like to thank all of our NAC members and to those who joined the meeting virtually, as well as our members of the public. I'd also like to shout out Michael Lauer, who started us on this magic wand, right? Who asked the question.
I'm happy to help.
Well, and if we sort of think about magic wand to reality, right, and how we can get there. So it's going to take all of us, right, together to move the needle, and we certainly appreciate everyone's engagement today. Please join us for day 2 of the NAC, which will begin at 9 a.m. tomorrow. And as a reminder, we will be reporting out from those pre-work sessions that the NAC had today. So with that said, I'm going to ask to close the meeting. All right. Thank you, everyone. Have a great evening. Bye-bye.
Oh, man.
That was an interesting conversation.
It was.
I'm not a big fan of that.
All right,
I am-
bravo.
Patient experience.